and afterward there was 10 years experience. So that is something. This is all the structure that it can be reached. Of course, the orbital reef, the Sylvian fissure, the uncus, and that midline. We can go from a factory groove to lamina terminalis, and in the limit, I will show you what are the limits for that. There is a very interesting contribution from Daniel Kelly about to use the endonasal versus supraorbital for a particular type of pathology of skull base, the craniopharyngioma and tuberculous cell meningioma. And I think that is quite important. And at the end, the main endoscopic surgeon, mainly endoscopic surgeon, he make clear the advantage to go through the KO supraorbital. This is a very interesting contribution that was done by Mario Zuccarello, comparing the usual pterional, the eyebrow approach, and the orbitozygomatic approach. And you see here in the cadaveric study that the green is the way that you can see directly with the microscope. And of course, the yellow and pink is getting when you tilt the table or tilt the patient. And you see here that the majority of the anterior skull base structure can be reached for the three approach. And of course, has to be chosen in fashion of the pathology that is harboring the patient. We did a kind of interesting study with the fresh cadaver in Vienna with Manfred Zabischer. You see here the opening, and that is what you can see. And one more important, you see here that the lamina terminalis is the limit. And if you see here this video, endoscope video in the cadaveric situation, you see that from this approach, you can go down till the brainstem, the clivus, and the basal artery. In the cadaver situation, is very easy because you can stretch the anatomy. In the human life, is a little bit difficult, but it can be done. The limits, as you said before, anterior is the criniform plate and crista galli. Brainstem, Sylvian fissure, and the bifurcation of the ipsilateral MCA, the lamina terminalis, as I show, and the ACCOM, and the bilateral, contralateral bifurcation. You can go till the chiasma to the opposite carotid artery and follow till the MCA bifurcation. So the pathology that can be reached, the plano and clinoid meningioma, the craniopharyngioma and the adenomas. The meningioma of the factory groove has to be a little bit asymmetric because you make a demolition of the crista galli or you have some difficulties to reach the bottom of the olfactory groove. Of course, frontal glioma, and I will show you some cases, some aneurysm, and one particular case is AC cavernous angioma nearby the ventricle or thyroid dysplasia. That was the case that was nearby the ventricle. I will show you. This is our series coming from the Besta and Sydney, 41 patients. This is the type of pathology. You see again, meningiomas is the majority, and but some epidermoid or dermoid cysts and some glial tumors. And we have 4 aneurysms. I will show you one case. And this is the other situation, my particular situation, because that was done by myself, while the other was done by the team. And you see here that we have, again, meningiomas, gliomas, and dermoid and cavernous syndrome. Let's see some clinical cases just to have the possibility to discuss. This is the presentation. The diagnosis is meningioma. And we can see here that for young people that are not prone to this approach, the opening is very important to save the basal part of the fascia, and not to go to medial, because there is the first branch of the trigeminal nerve, the supraorbital nerve. Of course, that's the decoration. That's the standard for all kind of craniotomy. You see here that in spite of having a small craniotomy, the space to work is quite good, and you see here the olfactory, the optic nerve, and the cellar region, and you can reach easily. You can reach the meningioma, and the most important thing is that through this craniotomy you can use also the ultrasound aspirator without any problem. And of course the balcony is what they are using to do in also with large craniotomy, with the other situation of meningioma. And it's quite easy to have a corridor in which you can work with with the usual instrument. And I think that is quite important. You don't need to have special forceps or the microsurgical and micro instrument. And that is the end of the and that is what is coming out. This is post-op. You see, of course, there is a pneumocephalus, but the meningioma is gone. Second case, very interesting because it came with a headache. I'm sorry. Second case, and that is the lady, and that is the scar that is later on. Second case is a patient that came for a chiari malformation with the syrinx, but with the right aneurysm. And we decided to treat the aneurysm before the syrinx. So that was the aneurysm. This is the angiography. You see here the neck is quite large, but is very keen to be clipped, and so we decided to clip the aneurysm instead to send to our friends interventional therapist. Again, the opening is quite similar. Optic nerve, carotid artery, and it's very important, as in all microsurgery, the sharp dissection, careful and but clean dissection. And you will see for here is the aneurysm, because that is treated as all kind of this type of surgery. Yesterday we saw thousands of this kind of pathology treated in a very different way. That is different approach, but always surgical approach. And I think that is something that young people has to keep learning, because they will inherit the most complicated cases. Here is the aneurysm. Of course, we can do ICG before clipping to see if there is perforant. The clip can be used. And the criticism that you have a little space, if you have a rupture of the aneurysm, is I can showing this kind of maneuver, you can really use also some temporary clip if you need it. And again ICG, and that's was the closure, and of course with some small plate. And this is the post-op, and the patient was dismissed 3 days after the surgery. What about endoscopy? This is a case of Charlie Theo, and it's very important to see here that with the space is enough to use the endoscope or to use a microscope to be assisted by the endoscope. In this case, is the part with the endoscope, and the craniopharyngioma is taken out in the usual way. I will say in the same way that you can do from transnasal approach. Instead, but yes, reverse down. But the space to maneuver instrument and endoscope is very similar. So I think that if you are trained to use endoscope, you can use also in this way. And that is a kind of touristic tour to see the chiasma, to see the vessel and pituitary stalk that is saved in this case. Again, another case of craniopharyngioma. This is a kind of anatomical approach to see what's, sorry, that again. In which for people that are not accustomed to that, to see what is pituitary stalk, chiasma, tumor. Let's go fast for question of time. And again, it's quite clear the situation. Another case of just going around in the basal anterior skull base. You see here that it's quite important always to have an anatomical situation, the recognition of the different structure. And again, if this webinar is neuroanatomy, it's because anatomy, in my opinion, remain the must. And also virtual surgery can help young people, but I guess that the only with the cadaveric dissection, one can really get the good hands and mainly good neuronavigation in mind. That means knowing the anatomy. Okay, so let's go on. Another case is the once happens is a typical meningioma, and that has 1, 2, 3 surgery, and again at another situation. That is the meningioma, the recurrent meningioma. This is all the craniotomy that she underwent during the last 10 years. So what to do? Reopen the frontal one. At the end, we decide to go from the orbital approach, and that was the post-op. And this is the lady. That was the previous one, and I say from the aesthetic point of view, is much worse the previous craniotomy that this approach. Glial tumor. The usual presentation. The tumor is this one. Can be reached from this approach? Yes. The only problem is that you have to move the microscope and mainly to move the patient on the table, because just to reach the lateral ventricles, as I can show you another case. This is the post-op, and this is the lady in the 3 months afterwards. Another case is another glioma. This is huge glioma, but can be reached, of course, with the usual craniotomy, but it can be reached also in this way, and that is the post-op. Talar dysplasia is a kind of very particular situation in which you can have those patients. If you have an epilepsy center, they make a selection, they make the video EEG, they make all the study that is important to reach the to be sure that this kind of alteration is responsible for all the epileptic pathology or epileptic symptomatology, I will say. That was after 5 years, he has a complete control of the seizure, as happens for all these kind of cortical dysplasia. So complication, overall mortality 2, 1 recurrent cleval chordoma and 1 GBM. Mortality morbidity is at 1 month after the surgery. Surgical mortality was 0. And the worsening of the pre-op symptoms was 0. New symptoms, diabetes insipidus in 2 cases, and that is the limits. You have to be very careful. The slight mild eyebrow paresis, because the muscle has to be cut and sutured in a very delicate way, and that's supraoral hyperesthesia because we went too medial and in contrast or in a conflict with the supraorbital nerve, trigeminal nerve. Transient morbidity is something that is there and it go away in no more than 3 months. So we got to the conclusion. It's a minimal invasive, so is fashion today, but it's very important that with this approach, you can have a very good approach to all the anterior skull base pathology. Of course, you have to be trained to more to the opening that when you get inside of the craniotomy. The space, as I show you with the Zuccarello work, is not different from what is the lateral frontal and again also the pterional one. The limit is the Sylvian fissure. If you have to have something that the pathologists go lateral to Sylvian fissure, that is a quite important limit. It should be used mainly in the ipsilateral side, but sometimes we can go also in the other side. And it can be full microscopic, only microscope, or endoscope assisted, or full endoscope. I think that the opening need always the microscope, and inside of the craniotomy, you can use only endoscope. And aesthetically, it's well tolerated to the patient. So thank you for your time, and that is the end.
Thank you so much, Giovanni, for perfectly being on time. And we have 2 questions for you. One is from Dilip Hiawat. He wanted to know, I think you mentioned that, but he wanted to know if what's your thought about using lumbar drain in these approaches?
I am in a generation in which lumbar drain was not allowed. So I never use lumbar drain. I guess that if you have careful opening and you open the arachnoid also in a very small, you make a small opening and you wait for the CSF is coming out, you do not need lumbar drain. I don't use a lumbar drain also for large craniotomy, but I think I have anything against, but I say that in my opinion is not so useful.
Andre has commented in the chat. Perhaps he would like to expand.
No, I fully agree with Giovanni that for the supraorbital approach, it is not necessary to do a pre-op lumbar drain to have larger access. It's, as you say, it's about the positioning of the patient. If you do that properly, the frontal lobe will already fall away a little bit. And you can, I've even used it in acute cases of subarachnoid hemorrhage, where there was maybe even like a tense brain, but it is a matter of waiting carefully, slowly, opening the Sylvian fissure, opening the cisterns. That's the essence. Like it is everywhere in skull base approaches, if you do a retromastoid, the trick is releasing CSF. And that sometimes it takes more time, sometimes it is very quick, but I don't use lumbar drainage for that. That's so it is not for me. But I see there are other comments on it. So
yeah, essentially, I think is
Henry.
the same thing as any other craniotomy anywhere else. The fact that the bone is smaller doesn't mean that one needs to do anything special to get in. It's just that in fact, the bone limits one's retraction. So, so there's exactly the same principles. Position, taking CSF from smaller spaces than from bigger spaces is to give you access deeper to bigger cistern containing more and more CSF. I think that's kind of the essence of it.
Right. May make a comment on that. What is say that Henry, it's very important the position of the patient, because you take advantage of the gravity, so the brain is going down. It's the same approach that you can do in the contralateral transfalcine approach for ventricular tumor. You put the patient in such a way that from the other side you can get where you want to go. In this way, you are not going to the other side, but the brain is going down. You have a perfect corridor. And it's true. It may sometimes take more time, the opening, that's the real treatment of pathology.
Henry?
Yeah. Thank you, Giovanni, for the nice presentation. I agree with you. We use the supraorbital eyebrow approach also frequently. Many people criticize the cosmetic result, but I think if you do the suturing in the right layer, it's really cosmetically a nice approach, especially in people with a bald head. It's a very nice alternative. I do not agree with your statement that craniopharyngiomas can be operated on in the same way like endonasal. What you have shown was a lucky case with an interoptic window, but many of the craniopharyngiomas have a prefixed chiasm, and you just see chiasm when you open it. And then it's very difficult. You go between carotid and chiasma or retrocarotid window, and then you have much more manipulation. So for craniopharyngioma, I'm pretty sure for most cases, the endonasal approach is much, much better, because you avoid any retraction. You have direct access to the stalk. You can identify it much better. So for craniopharyngiomas, I would not agree. I have done some via the eyebrow approach, but the endonasal, it's much, much better. And then I had one comment to the case where you showed with multiple craniotomies already.
Yeah.
And you chose a small one, but there was a bony defect above your bone flap, and that's why he has this indentation. So my question is, why you made not a standard incision, and you can make a palacos in this area, and then it looks much more nicer?
Well, the answer is
my choice.
The choice was also motivated by the problem of the skin, because this lady, for a question of time, I was shortening the history. This lady had also radiotherapy. So we were afraid that reopening the large craniotomy and fixing also the bone defect can make some problem in the suturing, or more in the follow-up on the skin.
Yeah.
The surgery was not so easy. So we decided that, and she agreed on that, and of course at the end we were happy, and she too.
Okay.
Okay. So, Dimat?
Very short. I know time is valuable. I just commend Giovanni on the presentation, and actually what you have done, what I call it functional exposure. So even the conventional exposure, most of that conventional exposure you don't use. You use the functional exposure, the 1.5 centimeter and 2 by 2 centimeter. This is the functional exposure you have achieved. The important step you have done from the beginning of the procedure, you release CSF. Otherwise, lumbar drain has nothing wrong with it. And somebody, I think, I have no Vladimir, the best invention for people used it is the lumbar drain, especially if you don't have the mass effect and worried about herniation. But the release of CSF, this is very important. The other observation on your procedure, you have not put retractors, which is very nice situation. Sometimes I leave a cotton ball at the corner under the frontal lobe, so it keeps the space open, and you do local retraction with your suction. These are my comments.
Thank you. So I need to do a very fast question about this before we move. And you know, I think with Matthias, I'm the junior in the team, and I really need you to tell us if you think in this general dogma that once you are getting trained, when you have less experience, it's better to go for bigger craniotomies, and then once you are gaining experience, you go to these kind of ones. I don't know what you think about that. This is a general statement, and I'd like to know your opinion. You think we can start doing this kind of minimally invasive approaches, so we have to be trained with the large one?
I think that young people have to be trained to small craniotomy for many reasons. The first reason is that if the craniotomy is small, there is less retraction of the brain. Of course, we have today, it was nothing like when I started. When I started my career, when I was a resident, the neuronavigation was a finger. So you have a large craniotomy, and with the finger, we are looking for the tumor. Today, we have neuronavigation, we have ultrasound, we have functional neurosurgery, functional neuroradiology, functional MRI. And I think that young people has to be trained to go in a small craniotomy. To go there, they have to go in the cadaveric lab. No way. Because it's the only way to understand. And I guess that smaller and smaller will be a kind of defense of neurosurgery. Yesterday, Ernest Niemi was saying that in China, they are afraid to opening of the brain, opening of the skull for the aneurysm. I think that is not only the China people, it's all around. And that is the advantage of our friend interventional radiologist or radiotherapist or radiosurgeon. Let's say is not invasive. I mean, it's stupid, but that is what the people thinks. So smaller is better.
I have to concur with Giovanni, and I think there is a recommendation made by the master from yesterday, Professor Yazagi, and I remember his statement many years ago. Early use of the microscope. Most of the traditional neurosurgeon, they like to make a big flap and they put the scope. He said, I don't need it. I need it at the end of the procedure when I want to put the clip or when I want to put the last piece of the tumor. This is a wrong concept inherited over generations. But I think in modern practice, as Giovanni said, they should put the endoscope, the microscope early in the procedure so they get acquainted. The small opening becomes a big open and mental deception.
Thank you all for your comments. Vladimir.
Just a little comment, Imad. You are telling that the young people should put the microscope as soon as possible.
Also,
but the older guys with glasses, we need to put it very early on because you do not see anything.
Exactly.
That is completely true. I visited Pernetsky and I was surprised. He said, I make skin to skin with a microscope. I think, what is this for bullshit? And now I know why, because the arms are too short.
No, I don't think it's a bullshit, Henry. And I think even I'll tell them when they start opening the dura, once the dura is open, they put the microscope in. And I think it's a valuable technique, especially if they are going to open the Sylvian fissure.
Thank you. Thank you, Vladimir. I just realized that I'm getting old also.
Oh, you are.
Maybe one anatomical remark just about the anatomy.
Because we have to move to the next one, please.
No, you have a lot of time. My presentation is very short. Please, Andre.
Okay. Thank you, Henry.
One anatomical remark on the supraorbital approach. Giovanni, maybe there's a little disagreement because you say mainly ipsilateral. The blind corner of the supraorbital approach is the ipsilateral olfactory groove. You can't properly look over the orbital groove into that. So the more anteriorly located meningiomas, you can miss them if you need an endoscope then. It's even more advantage to have the contralateral. It's easier to see the contralateral part. So we use it for the contralateral medial carotid aneurysms. So that part, I think that's the danger, that you leave something there. It's very tough to look over the orbital groove into that part.
Yeah, I agree completely. if the olfactory groove is very deep, you need a 30-degree endoscope. Otherwise, you cannot see it from the eyebrow. And the other blind corner, Andre, is the ipsilateral optic nerve. If you have a tuberculum stellate meningioma, you cannot look very nicely under the ipsilateral optic nerve. So if we have only unilateral optic canal invasion, I always come from the other side, because then I can look with a microscope directly.
This is what Panetsky always said. The supraorbital approach is an example of a contralateral approach.
Yeah.
You can use it very nicely for contralateral problems, even in the interpeduncular fossa.
Exactly.
So if it is around the brainstem, on the right side, you should do it from the left side. It's much wider view to that part, but just an anatomical remark.
Yeah.
It's especially true for tuberculum stellate meningioma coming from the opposite side. Because if you are drilling the canal, you are drilling it from the place where the remnant is.
Exactly.
Not from the opposite one.
Exactly.
Definitely.
Exactly.
And what's underneath the optic nerve, always opposite side. Always.
Yes.
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 Agree completely.
Just good to know for the people who have not a lot of experience in that you should carefully look to where the lesion is exactly located.
That's absolutely.
That's the key. So thank you for the great discussion. Thank you so much, Giovanni, for being there again. And it's my pleasure now to introduce Professor Henry Schroeder. He has been with us the last 10 months. So I really thank you for being here. And it's a real pleasure to hear to your lectures. I think you are going to discuss today about a case, giant ICA. So all yours. Thank you.
Thank you, Pablo, for the nice introduction. Thank you, Imad and Vlad, again for the invitation to join the webinar. I enjoyed very much and I learned a lot already. So this is a presentation of a case with a giant ICA aneurysm. And Imad wrote to me, I want to see a challenging case. I would love to have it again, to do it differently. So this is a case what I love to have it again. And you will see why. So this is a 45-year-old male. He was on vacation here on the Baltic Sea with his wife and his 10-year-old son. And suddenly he had first time severe headache. He took some aspirin and then it becomes a little bit better. And then again, it is third day, again, severe headache. So that's why he came to our emergency department and was admitted to the hospital. And he reported about his 3-day history of severe headache, but neurological, he was completely fine. Then of course, what we do, we make a CT scan. And then you see here, oh, oops. You see a lesion. It's without contrast, so it's a hyper dense lesion in the CT, suspicious of hematoma formation. Of course, we make a CTA in the same setting, and you see, obviously, there is a thrombus, and it is a partially thrombosed ICA aneurysm. Here you see the 3D reconstruction, shows the carotid and the big aneurysm. So what we do, of course, we want to know, did he has a small warning bleeding? So he got a lumbar puncture. CSF was completely clear, no erythrocyte, and also no zero phages. So there was no history of previous hemorrhage or an acute hemorrhage. Then, of course, we have to make in DSA to have a precise understanding of the aneurysm. And you see carotid here, big aneurysm, carotid going up here, here. So then, of course, what you do with a patient, we explain to him he has a giant aneurysm. It did not bleed, so it's no emergency case, but we advise to him to have a treatment. And you may agree that surgery is the best option, although nowadays maybe we would opt for a flow diverter, which could be sent here because we have similar cases, and it's astonishing when the aneurysm is completely disappearing and the ICA looks almost normal. But at that time, there was no flow diverter available. So I thought we can do microsurgery, maybe we have to do a bypass, maybe we can clip it. But of course, you have a high risk of the surgery. And so on Friday, I explained to him, and he should think about it over the weekend. And then I took the consent of him, explained everything to him. And then we scheduled the surgery for Tuesday, because on Monday I had a large tumor, which had also symptoms and required a lot of collaboration with other specialties. So we scheduled him for Thursday, and I thought of Tuesday. So I think it is good for him that he can think about it, because, you know, with the surgery, something can happen. He's now completely normal, and after the surgery, he may wake up paraplegic or hemiplegic or something like that. And then on Monday, he went to the anesthesiologist to get the informed consent about anesthesia. And while he was talking to the anesthesiologist, he suddenly had again severe headache and he vomited. But he said no, after a while he said, no, it's okay, everything is good. And he continued with the consent. And then he was brought back to the ward. And when he arrived, he suddenly became comatose with 6 fixed and dilated bilateral pupils. And then, of course, we make immediately CT, and you see a massive hemorrhage, which Fisher grade 4 subarachnoid hemorrhage. What we do, of course, immediately, we rushed to the OR and make a large flap, and you see the red and angry brain is visible. So we exposed here, you see optic nerve, this is the carotid on the right side. And then we try to dissect the neck of the aneurysm. This is A1, optic nerve. And then you see the hemorrhage is at the neck of the aneurysm directly when it was arising from the carotid. So probably it was an anterior choroidal aneurysm originally. So what we do, we put second suction in, small patty on the rupture side. And then I placed a temporary clip on the proximal carotid. Then I had temporary clips on the MCA and ICA. Then I opened the aneurysm. And you see still some blood coming, probably from the PCOM. And then a big clot comes out of the aneurysm. So then we can fold the aneurysm together and we have an understanding. So it was exactly at the origin of the anterior choroidal artery, but I could not preserve the vessel because there was exactly there the rupture. So we have this fenestrated rectangular clips, and I made a clip reconstruction of this broad-based aneurysm to reconstruct the carotid. So 4 clips were required to close this neck. Then I removed the temporary clips. Temporary clip from the MCA, ICA, and finally from the internal carotid artery. Then you make a flow measurement. It was a good flow. Then we did angiography. Initially, I thought it goes the different way because this was enhancing earlier, but this is related because the wall is thinner than here. That's why it was running the wrong way. This one day after surgery, you see the swelling, you see here, infarction from the anterior choroidal artery territory. We made the angiography. So there's a good reconstruction of the ICA. But you see after 14 days, you see that he had already and hypoxic damage of the brain because of this increased pressure immediately due to the rupture of the aneurysm. And 3 months after surgery, you see almost the whole brain is gone everywhere. So it was a disaster, and he remained in vegetative state. And then 6 years later, he died. But it was a disaster case. So what would I do differently? Just 1 day earlier the surgery, and we could prevent this disaster. So this was one of my worst cases, which I will never forget because he was really a nice guy. But I thought I should give him some time to think about, because he was completely neurological intact. And of course, if you have such a large aneurysm, you have the risk that he has some deficits, and everybody will say, well, why? He was completely normal, and I could not think about it. But he really said, no, I want to have it here. I don't want to go home. Let's do it here. Just I had this case on Monday. So in retrospect, I should postpone the day on Monday to Tuesday and make it. So I'm curious to hear your comments. Thank you for your attention.
I think, Henry, you need to blame anesthesia for that.
Yes, that is always easier.
Well, that's where the rupture happened, right? When speaking
Yes.
to anesthesia.
Exactly.
Thank you so much, Henry, for your honest presentation and waking us up about this important issue. I don't know if our colleagues want to comment on something.
Yeah, may I? Thanks, Henry, for that case. A very valuable lesson to learn. But I'm not sure whether I would have rushed into going for an operation on the same day, especially you haven't seen any subarachnoid hemorrhage on the initial CT scan, and also the lumbar puncture was negative. So I probably wouldn't have rushed him on a Friday for a major operation like this. I think it was the right thing to do. It was, in my view, he was extremely unlikely to rupture on the day before the operation. But I forgot, did you do a formal DSA or was it CT angiogram?
No, I showed it was a DSA.
Okay.
We did in DSA.
Yeah. I can't think of anything else I would have done differently apart from doing it earlier, but which I would have done it on a Monday, Tuesday in any case.
Yeah, Monday would be better. Just Monday.
No. That's only because you now know what happened on Monday. That's not fair. Because he could, if you had scheduled it for Monday, he maybe would have vomited and bled on Sunday.
Yeah.
I had an exactly similar case of a very young man. He didn't want to have the surgery. He had a slight oculomotor palsy. That was the only thing, and that improved. But that were the warning signs, the headaches and so on. There is something going on with that aneurysm. Something is in the wall of the aneurysm is going on, and it's increasing. And actually, when he finally decided to go for surgery, it was on a Friday, and I said, we don't do it on a Friday. And I rescheduled my CP angle surgery on Monday for that surgery. And on Sunday night, shortly after midnight, he was found dead in his bed. He bled. So you never know that. You never know it. And if you rush earlier into it and you would have a complication, people could blame you and say, why did you rush? He had no neurology. So why was it so necessary to do this so quickly if that would be an intraoperative rupture at the neck and having clipped the anterior choroidal at that time? So it's all the ways around. It is difficult. And this is the hard part of it's a hard piece of cheese to swallow.
Yeah, it's difficult. But I think there was a kind of dissection in the wall. I think this was the cause of the severe headache.
Yes.
And there was another dissection, and then suddenly it bled. This is my theory.
Is symptomatic.
Henry, I would say that was pure bad luck. You know, we all have the similar cases. I have a brainstem cavernoma who bled 2 hours before scheduled surgery. Brainstem cavernoma, you know, and this is the complication which I call management complication. But you only know this with the hindsight.
Of course.
that you made a mistake.
Yeah.
You know, should you be operating on a case earlier and he would be hemiplegic, you would be showing the same case, telling us that you made a mistake on rushing him too early to surgery.
Yeah.
That's nothing wrong with this.
May I, Henry? I have a very similar case. It was the mother of a friend of mine, and it was I give to them 2 days to think about for the family and so and so. It was completely intact, and she was found dead in the bed during the night. So this is something that you said early, you do, better it is. On the other hand, I have a suit case, a medical legal case, where the accused was that the consensus was done the same day of the surgery. So, you know, I don't think that you can feel if I did in a different way. I think that you did the right decision. Leave 24 hours to think about and give the consensus 24 hours before. And unfortunately, the aneurysm was against you, against him.
Yeah. All right. Thank you for the comments.
Tom, can you unmute yourself?
Any other comments? I think Pablo may have to disappear to his clinic shortly. So
No. I'm here for until 3 p.m. But all yours.
I guess we focused on the sort of ethical issue and sort of timing of the management here. Anybody has any comments about how to manage sort of technically the case? I mean, of course, Henry himself was saying that, particularly with the hindsight, there might be consideration of a flow diverter, but again, I suppose people can talk back and forth whether this would have made any difference, because probably if this was anterior choroidal, was very likely part of the dissection, part of the rupture. So any comments about that? Anybody?
The only thing I can think of is I think with a flow diverter, you need to pre-treat them with a double antiplatelet prior to the procedure. And someone like him with a high risk of rupture, I'm not sure whether a flow diverter would have been a choice at that time, because the risk would have been fairly high in that case as well to rupture.
2009. This was 2009, so very tough to. The flow diverter was not so much available. I think the only one was the initial part of the pipeline.
Pipeline had a high rate of hemorrhage at that time.
That was the only one at that time. I think after 2011 and 2012, that was when more flow diverters came. I think the Surpass started at that time. So I agree with Henry that at that point, I think, and all the years before, surgery was the best option for this patient. Absolutely.
Going for the
Otherwise,
future.
The natural course, it proved that the natural course was also a devastating one. He ruptured. And if he would not have been in your clinic, he would have found dead at home.
Yeah.
Yeah. It's hard.
Just on this point, going so that for the future, of course, it was 2009. Would the vascular surgeon in the audience in the panel have considered flow diverter as a choice number one here or not? We have heard Ramesh making a point about the pre-treatment required. Any points?
Well, our endovascular people, I mean, we do it in their own neurosurgical department. They don't like it doing in an acute subarachnoid case. So, but if there was no hemorrhage, then I am sure that they would have primarily opted for flow diversion. Yeah. Nowadays, I mean, now to 2020, 2021.
That's what I wanted. So I think we covered.
Not in an acute subarachnoid case. That's where they absolutely not want to use flow diverters.
So I think that we covered. Yeah. We covered the case comprehensively. I think this clarified this potential question about flow diverter, yes or no. and we agree that in the context of acute bleed, this would have not been an option anyway, really. Okay, well, I think we will move on, and I'd like to introduce a good friend of mine, Ramesh Nair, who has a busy practice in London, based primarily in Charing Cross, but operating pretty much in all hospitals that are in London. He is also affiliated with Imperial College and is associate, editor of British Journal of Neurosurgery, and passionate educator. That's why we have him here on this on this show. And Ramesh, you are on now.
Thanks, Tom. Thank you. I'm just going to start sharing my screen. Is you able to see my screen now?
Yes.
So it's going in the same theme about whether I would have done anything differently. This is a case I remember happened in 2015, I believe. Yeah, so he was a young man. I mean, he was 55. He's now 62. He was an electronic engineer. Came to see me after being referred to the ophthalmology service with a large pituitary tumor. He had a visual deficit, quadratic defects, superior quadratic defect from this large pituitary tumor. So you can see the giant tumor has got lobules around the ACOM complex. All this knobbing you see are where the tumor is trying to grow between the ACOM complex. And this is what happens when you have tumors which trying to push. You can see that even it is pushing the genu of the corpus callosum upwards, and so it is exerting a lot of pressure. But interestingly, the vessels tend to hold more strongly than some of the other neural structures, and the way it extends through this areas behind the ACOM or in front of the ACOM, and also to the sides of the anterocerebral arteries. So this is why it gets that shape. So that's the axial view showing the incorporation of the anterocerebral arteries. All this grooves within the tumor are where the vessels, and these bright spots are the vessels inside the tumor. So it was not a straightforward pituitary tumor, even though it's not unusual to see pituitary tumors of this size in our practice. In fact, if you look at all the pituitary tumors, around 15 to 20% of them could be large, giant tumors. Some of them could be functioning, such as prolactinomas, but there are many of them. In fact, half of them could be non-functioning. You can see the way the tumor was growing and partly going into the frontal lobe here. On these vessels are inside it. They're not strictly inside it. There is a pseudocapsule separating it, but it is encased around it. And this will come to our, if we can look at the classification of the grading of the suprasellar extension, just to remind the trainees in the group, there are classification based on the extension of the tumor into suprasellar space, depending on how far it's extending, whether it's extending up to the third ventricle or whether it's up to going on to one side to the frontal lobe or temporal lobe. You can grade them. And also the sideways extension, we often use the NOSP classification. So angiographic image would tell you how much the vessels are displaced. Here you could see that the anterocerebral arteries were sort of displaced up, elongated, and they are much lifted up. In fact, I remember for tuberculum cellular meningioma, we used to call this as a guard of honor sign. When the heads of state visit other places, they get a guard of honor. Just like that, in meningioma, especially suprasellar tumors, they tend to lift the A1s up, so you get this guard of honor sign. So this is fairly similar sort of appearance on the angiographic image. The sagittal CT, you can see the sinus was pneumatized, and the cella was expanded. Tumor was going into the cellular floor. He had all the workup, endocrinological, ophthalmologic workup, and the planning with the reconstructed image of the carotid arteries and the circular villus and the large tumor. And this being a large tumor, I planned an extended endovasal approach rather than a standard transcellular approach. Because if you go back, you can see that the tuberculum here, ideally if you take it off, you could get all this out. So this is the standard exposure for such a case. The cella is here. You can see the cella is filled with the tumor. The exposure is from the paraclinoid carotid to the paraclinoid carotid and the planum, and the planum cella, the dura is being opened up. This is where the anterior intercavernous sinus, the limbus is here. So the dura is being reflected. It's not the usual opening for a pituitary tumor. Normally I open it like a cruciate incision. So the tumor is now being exposed. It's soft tumor, and you can also see in the planum the tumor was coming down into the exposure. So the dura is being dissected off, and soft tumor but vascular. So the initial exposure of the tumor is fairly soft, as long most of the pituitary tumors are, and as you can expect, they are vascular as well. And part of the debulking, you can see the anterior vessels are appearing on the upper surface. This is the A2s bilaterally, and can you imagine there will be a pseudocapsule which is also attached to the arachnoid here. So there is no arachnoid attached to it. So it's important to make sure that these perforators are preserved and they're not damaged by trying to peel off the arachnoid off these vessels. Most of the operation was intratumoral, intracapsular, but there are tumors around the side base as well, so we'll go on. So this is the side of the tumor is getting exposed and removed. That's the supraclinoid carotid going up. So this is the just to confirm the position of the supraclinoid carotid with the Doppler. Okay, so the navigation is useful to locate the extent of your operation, and all this reconstructed image will tell you where are the vessels A1s and A2s are displaced by the tumor and how the tumor is growing between those sort of corridors. Here, this is the ACOM complex here. The chiasm is here, the pituitary stalk and the pituitary is at the back. So everything is in front of the cella. And this is the A1 on the left side. This is hidden behind the capsule, but you could still see it. So just to correlate the anatomy, so this is a cadaveric picture showing the A2s on here, the ACOM is here, A1 on the left side, A1 on the right side, on the left side and on the right side. So the tumor was going all around these corridors, and part of the tumor was going into the frontal lobe. So which is what you see here. So this is the part of the tumors being removed from the front of the ACOM. There's tumor around this corner and also towards this corner. So it's important not to disrupt these perforators which are coming back from the A2s, and be careful with it. So these tumors are this is the tumor being removed here, and you can see there was no plane which is emanating to the brain on that side. So it's fairly large exposure. It's about 2.5 to 3 centimeter long incision, final flap. So he did well after the operation. I was oriented and talking, and I was pleased that he did recover his vision as well. And he did an MR scan the next day. The tumor mostly was removed, and could still see whether the fluid was within the cavity. There was a little bit of tiny left behind here, but he remained well. So I was not concerned from a neurosurgical perspective. Unfortunately, on the 4th day, he started having intestinal bleed, subsequently also developed respiratory distress, and had to be shifted to ITU. His respiratory distress worsened so that he had to be intubated and ventilated. And also his X-ray chest and subsequent scans have shown a lobar consolidation, and his intestinal bleed became a real problem. He started having significant loss, and hemodynamically he became unstable, had to have several units of blood transfusion. And the intestinal specialists have done the endoscopic investigation, which revealed some mucosal erosion. There's nothing more major ulcer or duodenal ulcer or anything that require any surgery, but he was losing blood. And the scan we did while he was in the ITU with ventilated showed this hematoma. It was, I suspect this was a fluid. It's not a very a significant clot. It's just a fluid blood. But that time he didn't have any other concern. But after a scan subsequently revealed that he had a significant pneumocephalus, and also in the ITU he started leaking CSF. So we were concerned, so we had to take him back to theatre to repair it. So this is when he was very sick with all this bleed going on, when hemodynamically unstable with a low hemoglobin, and so things were getting more and more complicated. And also had developed collapsed lung, subsequent CT pulmonary angiogram revealed pulmonary embolism. So he had to have an IVC filter put in. So we are in a situation where he has got pulmonary embolism, and we cannot really heparinize him or treat him with anticoagulation because he's having ongoing issues with his intestinal bleed, and also had recent endoscopic surgical repair of his leak. And from a neurosurgical perspective, the leak stopped, and the wear in the ventricles got better. And these are he had multiple stages of interventional procedures for his intestinal bleed. In fact, they found that his celiac artery was quite stenosed at the base, so he was getting collateral circulation in that territory by other mesenteric branches. Possibly it all contributed to his intestinal bleed, and you can see the coils in the mesenteric artery, and at the background you can see the inferior vena cava filter. So he spent some time in the intensive care unit, and had to have a tracheostomy and subsequent CTs, and also later on found that he's got femoral and iliac vein thrombosis, and he did have an IVC filter put in, so we didn't have to do anything about it. And subsequently we removed the external ventricular drain, and he can see some low signal sort of low density areas in the anti-sublatory territory, but there was no extensive anti-sublatory infarction. After he came back to the ward, he recovered to some extent. He was still quite disabled by all these procedures and the bleed and the ischemic changes, and he was sent to a rehab unit to a local center. And this is the scan they did a month or two later, where they did this MR scan. You don't see any tumor. You can see the fat graft after the repair, but you can also see this anti-sublatory infarction, mostly on the right side, a little bit on the left side. So it was not there when he was with us. So it sort of developed a delayed ischemic response to all these procedures. When the family came to see us after he was in the rehab unit, and they said he was making slow recovery. He was able to speak. He did have some weakness on the left side. I was actually astonished to hear that they were not discussed in terms of the risk involved, because when I met him, he was alone, and that was a bit of a surprising thing for me. In many countries, when you see patients, they come with their whole family, and the whole family will be there to support this patient. But in many countries, especially in Western world, they come alone because they are very individualistic and they don't really want to bother their family. But such a big operation, the family didn't know about it. So this is something which I was surprised about. So what is there anything I would do differently? I often used to wonder whether draining that liquid hematoma, whether it would have made any difference to his eventual outcome. Probably not, because he remained clinically well in spite of having that hemorrhagic cavity inside there. I think overall the multiple episodes of his hemodynamic instability may have contributed to his anticephalatory infarcts, because there was manipulation of the anticephal arteries, there was blood around it, and added to this with the bleeding episodes that may have prompted the ongoing delayed ischemic changes. And on top of that, we had another complication issue of pulmonary embolism, and which we could not really treat with anticoagulants. And also, we also had to deal with the leak and pneumocephalus, etc. But one thing I would have definitely since then, I think even if they don't want their family to be involved, I think we have to make every effort to get the family, because once something happens like this, it will be the family who will be looking out for these patients, and especially if there is a cognition impairment, there is no excuse. So my take-home message from this case would be, even if it is not so major case, I make every effort to get the family in the clinic or even beforehand to have that discussion. I think that is it. This is my team here. Also you can see my hospital and the sculpture, which is the shape of a spine, and these small individual things are made in the form of a female torso stacked up like a vertebra. It's a famous culture called Com Femi. Thank you very much. I'm going to stop sharing. I would like to hear the comments.
Thank you very much, Ramesh. Imad has a question, but before he goes, just say that we all very much recognize the difficulties associated with the giant pituitary adenomas. They come in all sorts of shapes, sizes, consistencies, etc. Imad.
Yeah, actually, the situation is an unlucky situation. It's a multifactorial problem, as you said, whether it's the intestinal problem and the lung embolism. I have confronted with a similar case on a craniopharyngioma that I attempted to, by default, to take it from below with some calcification. And I have the same situation. Everything was clear, subarachnoid dissection. And I saw these perforators you pointed out. This, I think, sometimes is a source of problem, like in vasospasm. That's what you have it, even if you go from above, sometimes you have vasospasm. And I think stroke or infarct related to these vessels, that's why the delayed effect of it rather than earlier effect. It's not a bleed per se immediately by the procedure or by the technique, but it's a delayed, perhaps sometimes unnoticed, some traction injuries on this perforated that can lead to these vascular. I just want to mention vasospasm can occur by this procedure.
Thanks. Thank you.
Yeah, that has.
Yeah. Andre?
Yeah, indeed, that has been described. And actually, I'm right now, this week, I'm writing on a report as expert witness on a similar case. And there was vasospasm, because for nearly 48 hours, that patient was well. And then at the end, he developed bilateral thalamic infarctions. And there was some, the diaphragm was open, so there was some blood in the suprasellar cistern on the post-op CT scan. But what adds to the problem, and I think that Ramesh pointed it out also about the family, if so many other issues evolve later on, and that was also in this case with a lot of tracheostoma, long-term in the ICU, multiple other specialisms are involved, the family hears, what they hear are 20 different stories from doctors. We tell them our neurosurgical view, and we see some liquid blood in a field. The ICU doctor tells the people he has a bleeding in the brain. And so they all give different opinions on the situation. And that adds to the confusion. And at the end, loss of confidence in the doctors, in the medical team. So therefore, it is so important, even if there are multiple other complications, that the neurosurgeon who treated it first remains the captain on the ship. and is in a daily, preferably daily basis, the person contacting the family. That was so obvious in this case. I'm just busy writing it all down now. And that's because this typically happened afterwards. There was this, at the end, the feeling of somebody for 1 year in a rehab center, and the family say, how is this possible? We heard a lot of different stories, and it comes from this and it comes from that. Early involvement, and at the end, always be available as neurosurgeons. And I tell that to the young people. Don't leave it to others. That's so essential, because it's all pointed to your surgery.
Yeah, totally.
Lots of very important points there. In fact, the reason I missed the session yesterday, I had pituitary apoplexy in a giant pituitary adenoma. So I relieved the experience, including the fact that the patient had no family contacts, and I tried to really speak to somebody, but I simply couldn't. So sometimes it is can be very complicated. Any other points? Perhaps what I'd like to mention here, and if I can briefly share this screen, I can't see. Oh, there it is. Can you see the screen?
Yeah.
Hopefully, I can't see the screen myself now, but hopefully you can see the set of suckers.
Yeah.
Yes.
Yeah. So this is not from yesterday, but from a case, and particularly I find useful to have sort of bespoke curvatures on the suckers, and often use two sucker technique in cases where there are lots of lobules and nodules. It is of course not applicable to hard tumors, but the ones that are suckable or semi-suckable, this is quite a gentle technique that allows one to stay within the capsule, even if there are nodules and so on. I highly recommend it in a number of cases.
Yeah, I agree. I think the Kazan kit, which we have for the extended procedures, we have like a curved sucker, but I think having more assorted range of suckers will be quite useful. And I also like the two suction technique with each hand to go into corners, especially in the cavern of sinus.
Okay, I'm not sure whether Sanjeev is around. I was sent a message.
Sanjeev is here. Sanjeev is here.
Sanjeev's here.
Nikolai is ready again.
going to be last.
Sorry, I'm having a minor technical issue which I'm trying to resolve my new laptop.
Perfect.
So if I could go last, that'd be very helpful, please.
No problem at all. We
Thank you
have
very much.
Nikolai with us.
Hi, everybody.
Are you okay to go?
Yes, I can go now.
Perfect. So it's a true pleasure to for me to introduce Nikolai. He is on the call from Belfast. He's accomplished surgery in a number of areas, including vascular, skull base, and spine, and probably more. But that's the areas I know him particularly from. And he's going to be talking to us about giant cervical chordoma with VA pseudoaneurysm and VA bleed, which is precisely at the junction of all his specialities. So Nikolai, please go ahead.
Thank you so much for the nice presentation. Immense pleasure, as usual, be with you, and I'm happy to present one of my cases. Let me just share my screen, and let's go on just to start presentation. So I'm going to present to you one of my cases, which I will always remember because that case shook me a bit. It was a ruptured vertebral artery during one of tumor removals. This is where I come from. For those that don't know me, welcome from Belfast. This is my institution. Just to give you a little bit of a background, vertebral artery, 4 segments, as you probably know, just to refresh your memory for the juniors. The first segment is starts from the subclavian artery and goes to the entrance of to the transverse foramen of C6, usually accompanied by 2 veins, thoracic duct on the left side. So be careful when you go around there. Then the next segment V2 is from C6 transverse foramen to the C2 transverse foramen. Abundant venous plexus, periosteal sheath, so you still have some margin for error. If you try to go in there, first thing that you're going to see is venous bleeding, but you still have to be careful. V3 is C2 transverse foramen down to the foramen magnum, and this is probably the most injured segment. It's quite mobile. There's abundant venous plexus, and you have to be careful about the variations at C1. And then the last segment, V4, is from the dural penetration to the vertebro-basilar junction. Where it forms the basilar artery and then contributes for the posterior circle of Willis, posterior section. A little bit about the variations of the vertebral artery. Nearly half of the vertebral arteries are dominant on the left-hand side. About a third is dominant on the right-hand side, and you have codomination is a quarter of the cases. About 5.4% of the vertebrals are anomalous in course, so you have to be very careful about that. Just to emphasize that, this is the so-called famous, famous picture of Uga from 94, but you can see another picture here, which I borrowed from Ed Benzel. You see these kissing vertebral arteries. Just imagine you have to do something anteriorly on that spine. You have to think twice, and you have to be very careful, or maybe even think about alternatives. So just to give you a nice paper that I have found, what's happening when you rupture the artery. This is a paper that was published by Cervical Spine Research Society. 141 members. They managed to get combined 163,324 cases, and out of these cases, they had 111 vertebral artery ruptured. So as you can see here, about 76% they did a direct tamponade, about 29% they managed to ligate the vertebral artery, about 13% they managed to repair, 11% embolization, and about 5.9 stenting. The surgery that was giving the biggest number of vertebral artery rupture was the posterior work on C1, C2 segment, but see the second one. The second one is the anterior corpectomy. This is something that not everybody appreciates, and quite often people dive there and they have surprises. Luckily, vertebral arteries are forgiving. You can see here that 87% didn't have any sequelae following vertebral artery rupture, but still significant percent, about 5 died out of this 111, so still a very serious complication, and you have to think seriously about that before, and you have to try to avoid it. So my case, it was a 19-year-old girl with a very slow progression of a tumor, first diagnosed in 2011, started only with neck pain. This was actually followed by somebody who I have inherited. He was working in my place, and then I joined in Belfast in 2015, and I started following this girl. The first consultation, I have noticed that she's slightly dragging her leg, and that was what I have noticed. And then I have started working on that. I have started following her closely, and then finally we have decided to go and operate. This was the tumor. When I have decided to operate, the girl was slim and tiny, and it was possible to palpate this tumor through the skin. So this was of course, I did an angiography, and this was the angiography. You can see that the vertebral artery is displaced, and the tumor has eroded the two of the joints and the vertebral body here, as you can see. And this was from the beginning, I knew that this is going to be a challenging case. But what I have not appreciated, that there is a small pseudoaneurysm that was initially not reported, and it was not communicated to me, but it was discussed on a vascular NDM. So this is the intraoperative pictures, unilateral approach. I started with debulking the tumor, and then literally I then dissected the capsule, and then literally with the last bit which I took, which was complete clearance of the tumor, I had the massive bleed that I don't wish you to see, but if you see, you have to deal with it. So I managed to stop the bleeding, but I had probably about 2 liters blood loss for about 20 minutes. So it was pretty alarming and pretty shaking for me. I managed to stop it with muscle, with hemostatic materials. But because the tumor was completely gone, and as you have seen, it was a big cavity, I had to fill that cavity with something, because I was afraid that the tumor will rebleed. My next step was already planned. I had to do an emergency endovascular treatment, the patient to be stabilized. But I was afraid that by moving the patient to the cath lab, I might have a rebleed. And as you have heard, this was a major bleed with a lot of bleeding. So I decided to tamponate and to fill the cavity that was tumor before with swabs. And then I closed the wound. I've done this before only once in my life. I had to close like that a temporal AVM that was bleeding a lot. So I had some experience with this. This was not something new for me, but I don't do this every day. So after I have closed the tumor, the skin, then the patient went to the cath lab, and as you can see, 2 coils were deployed to exclude the rupture from the circulation. And then I have done another surgery in 48 hours after the patient was stabilized to remove the swabs. And then I planned anterior cervical surgery in 2 weeks. You can see here the coil going out. This is where the rupture site was. And you can see my approach. I managed to do unilateral approach only, preserving the midline structures. And then I had the other dilemma. I had to stabilize this neck, because 2 of the facets were missing and half part of the vertebra was eroded by the tumor. So I didn't know what to do. I decided to ask my colleagues on formal spinal MDM, and they said that I have to go and put screws from C4 down to T2, which was a bit excessive for me. I was not very happy to do that, and I decided to go against the advice from the MDM, and I designed kind of a off-label option, and I have decided to go anteriorly. I put these cages, which are zero profile cages, which will allow anterior fixation, but also stabilizing the cage inside the disc space. And why I wanted that is because, as you can see, the vertebral body is partially eroded, and it was a very tiny vertebrae, very small spaces. As you can see here, the posterior contour of the cage is right on the posterior vertebral line, so I didn't have so much space for displacement, and that's why I wanted to use these cages. And then I needed to have some buttressing because I was concerned about possible kyphosing in the future, and that's why I put a plate for reinforcement on top of that. This is 1 year follow-up. You can see that fusion is happening here and the patient is doing well. This is post-operative MRI scan that shows some pseudomeningeal cell, but it was a big cavity, and that's just filled with CSF. But this was asymptomatic, and I left it behind. 2-year follow-up. Still, patient is doing well, and I have discharged this patient. I think she's now in Australia. So lessons learned. What I would do differently now, I would go back and I would spend a bit more time with the angiographies, and hopefully I will see that pseudoaneurysm. That will spare me this experience. Of course, prevention is better than dealing with the problem. Endovascular service agreement. Before I start the case, I spoke with the endovascular, and they said, "Oh, we can embolize it for you because it's not dominant artery." And I said, "Okay, I'll go ahead with that, but I probably will reconsider that." When you have bleeding, the most important thing is you have not to panic. You have to just stop it with something. Put your finger, put swabs, put whatever you have around. The most important thing is stop it, and then you have time to think. You have to think out of the box because these things are not happening quite often. We don't have a lot of literature. We don't have guidelines. We don't have consensus. We have only expert opinions. And we have to quite often design our own approach. And that was it. Thank you.
Thank you very much, Nikolai. This was a complex and certainly tough case, which didn't end when you turned off the tap. It required further work, and lots of lessons to learn, not least how important it is to be patient. And I'm referring to the fusion process, as well as how important it is to ask for advice, yet keep your own knowledge and perspective of the patient. Any questions from the panel? Comments?
I just want to ask briefly about the pseudomeningeal repair. Do you see there's a need to maybe repair that in the future, just in case that woman will ever have a procedure on the neck, right? The next surgeon getting in there may be in for a surprise if you have to, I can't come up with a procedure right now that she may need, but an asymptomatic patient usually doesn't require repair, but just given the size of that fluid collection, does that, you think, limit her activity level in the future in terms of sports? Is there risk of
Yeah, it was completely asymptomatic, and this is actually the cavity of the tumor that was filled up with fluid, rather than a true pseudomeningeal cell. There you can see a dura. If you carefully go through the MRI scan, you probably see a small fistula there. That is because that fluid should come from somewhere, obviously. But it was completely asymptomatic, and it was not causing any problems for the patient. And with regards of if somebody encounters that by chance, if I'm a surgeon, I would like to, and if I'm going somewhere, I would like to see some imaging. So if the surgeon is not doing that, then it's going to be bad surprise.
Can I say something?
Ramesh?
Thanks, Nick. It's a harrowing experience to have such a big bleed for an operation. I can only think of similar sort of arrangement for endoscopic approaches for chordomas in the skull base. You always think about the carotid damage, especially in the petrous carotid, and there is no other layers for the carotid to be protected. So it's quite easy to get a rupture. So I think what you did was appropriate to get the endovascular team on standby. That's what that's recommended for such cases when you do big chordomas, especially of the skull base, or even in your case, vertebral case, to alert the endovascular team on standby, so they may have to deal with it. And one of the things which I wonder whether a formal DSA, apart from a CTA, whether they could have diagnosed the pseudoaneurysm beforehand, and then possibly if it is an equally dominant or a less dominant vertebral, they could have coiled it off before the operation. Then you probably could have avoided that situation. That's one thing. Second thing, only other thing which I can remember from my experience about vertebral artery injuries, when I had a patient who had a delayed vertebral artery rupture at the C3 level and presented with a big hematoma 2 months later, and then bled torrentially and had to be taken to theater. Then I had to expose the V3 to directly clip the vertebral artery. So that's the only experience I remember in terms of vertebral artery injury.
Iman.
You're muted.
Yeah.
Sorry, I could not understand the images you put on the cervical spine AP. It shows the bone and a faint flow in the vertebra. Was it a real CTA as Ramesh suggested?
It was a just CTA, simple CTA. This was, we did not do
simple because it did not highlight the vascularity very well based on the images. This is one. And I think the other one, if you confronted with this case again, you mentioned it in your conclusion, but I want to hear it again as a message for the young people. If you confronted with a similar lesion, you will go ahead and do a proper CTA and you got your endovascular doing the whatever they want to do, coil stent or whatever.
Yeah, absolutely. So my question to radiology was which one is dominant, whether this artery is dominant and are not. And I stopped there, and this was probably my mistake. I had to dig deeply, and I had to ask for a proper DSA maybe just to see what is the vasculature. Yeah, this is something that I would do differently, definitely. I agree with you completely.
And this is why these meetings are so useful, because in neurosurgery, a lot of cases are very unique, and it is quite some time before we come across a second case like that. And if we can learn from others, you know, we are much better prepared for the next surgery we're going to do. Unfortunately, we have to move on. Ek, are you okay to present now?
Sure, I can do.
It's a true pleasure introducing Ek, a long friend of mine through the WFNS Anatomical Committee, which is a great group and a privilege to be part of. Ek is a professor of neurosurgery at McMaster University in Hamilton in Ontario. He has quite a varied practice and wide-ranging practice, but one of his special interests is ventricular or paraventricular surgery. And in fact, he's going to be talking to us about ventricular surgery today in the context of a tumor under Sturge-Weber syndrome. Ek.
Thanks so much. Thanks for having me, Imad and Vladimir. I came across this case in the last 6 months during COVID, and I wanted to share a little bit what I've learned from it and put it into the context of, what do we know about management of meningiomas in the ventricle. I have nothing to disclose. I just want to, for introduction purposes, briefly bring up brain tumors, intraventricular tumors, and meningiomas as such, and then give you 3 scenarios that I encountered where I learned from intraventricular meningiomas, and hopefully we can discuss this a little bit. So overall, brain tumors are rare, constitute only about 2% of all tumors, and your lifetime risk to develop a CNS neoplasm is really only 1%. However, that incidence seems to be increasing and affects Caucasians more than other races, and in general affects males more than females. Amongst those tumors, the intraventricular tumors are rare because they only make up about 1% of CNS disease. And when you think about those, are they really a rare problem? Well, you could say yes, because 1% are located strictly in the ventricle and most frequently so in the trigonum. But no, because up to 10% of all brain tumors involve the ventricle. So it's good to know about, what do you need to think about to manage this type of disease. I start with classification of an intraventricular lesion by using all imaging modalities on the market. They are good for delineation, but they're not specific for pathology. Really, location of the mass and the patient's age puts the best context and gives you the information for a differential diagnosis. If you haven't done this before, start with categories. Is this solid versus cystic, which will help you in making decisions about how to manage this? And could it also be non-neoplastic, because there are parasites occurring in the ventricle that look rather similar? Useful subdivisions are based on the site of origin. For the lateral ventricle, the ventricular wall is usually a rise of ependymomas and that group of diseases. If the lesion is strictly limited to the choroid plexus, you may encounter meningioma in adults, so solitary fibrous tumor. In children, you need to really think about papillomas and plexus carcinomas. But if it's of mixed appearance, it can be a host of different pathologies. And all pathologies in the parenchyma can also occur in the ventricle. So for today, we just want to talk about meningiomas. And meningiomas have been known to occur in the ventricle for about 150 years. They make up about 10 to 30% of all intraventricular tumors, but only about 1% of all intraventricular meningiomas. So none of us has a big series in this in the real world. One of the first ones, again, to report on this topic is Dandy. He was actually quite creative and showed us how to address this initially with rather crude manual removal. But we have learned a lot since. Of those reported in the literature, there seems to be a gender predilection for females, which is not different from the general population. And you just need to think about that the pediatric population has more intraventricular meningiomas than the adult population. They do develop largely in the lateral ventricle with 80% of the cases, and the ones in the third and fourth ventricle are rare events. So I'd say for the purpose of today's talk, we skip that. What you need to know about is not so much the site of origin, but the vascular supply. And I should encourage all of you to study the vascularity carefully. In the trigonum, you have usually supply both from anterior and lateral posterior choroidal arteries. So there is a collateral network that may surprise you. In my early 10 years of my career, I've done 12 of these cases. So I come across maybe one per year, I'd say. And that distribution followed the normal distribution in the literature. And I presented this once before in Rome. All these patients in my practice were symptomatic. The problem with these patients is they present rather late. The location is such that they really present with general symptoms more than anything else. So headache, nausea, vomiting, dizziness is key. Sometimes mental status change and vision changes. And patients are usually just sent in with a CAT scan. What you should recognize is the so-called syndrome of the trigone, which is this weird combination of weakness and hemianopia plus dysphagia if it's on the right side, and maybe problems with spatial perception calculation on the right side. And there may be additional ipsilateral cerebral peduncle symptoms if the mass effect is big and the patient has compromised to the tracts. This is my management outline. If it's an incidental finding, I wouldn't do anything, but all patients in my practice have been symptomatic, and since non-incidental findings come to you, they're usually surgical. So patients want to know all their options. You need to counsel them about all surgical options as well as alternatives. For me, these lesions are essentially surgical. Are these lesions a challenge? Yes, because they are rare, and yes, because they are surrounded by high real estate, and usually experience is lacking. But if you use your experience from other cases and you follow the same principle, it works. So rule of thumb is, what's the risk for surgical treatment? Not different from a knee replacement, I tell my patients, because they just need to be reassured that you're not trying something crazy the first time on them. And in reality, the symptoms and risks are pretty much identical. The major complications in intraventricular tumors is not different from others. I usually divide them into major complications, about 5%, neurological deficit that could stay, not likely, but you need to tell them. Minor complications, maybe 10%, which is a guesstimate. We have many open routes to get in. So you need to know your anatomy and topography, and I use all imaging modalities on this tumor. I do not save any costs. It starts with, as much as we know where the ventricle is, use navigation as well, because it helps you with positioning and access planning. Know your topography. So this is a view into the left-sided posterior lateral ventricle. If you look from the occipital horn, the glomus of the choroid plexus sits in the middle. The thalamus is deep to the left. The body of the lateral ventricle is superior. The corpus callosum is medially. The Amund's horn and hippocampal formation is coming inferiorly, and the occipital horn is towards you. If you now lift up the choroid plexus, you will find the choroidal fissure, which you may need to deal with, and the fornix inferiorly. You always have to protect the fornix, especially on the left side. There's a beautiful paper by Kawashima that I want all residents to read. It really summarizes beautifully how to get into the atrium, all technical approaches, pros and cons. in small numbers. I usually say this is like a bird cage. You try to steal the bird out of the bird cage without opening that cage, and that is pretty much true. It's very different on the right, on the left, so I want to give you 3 scenarios. This is a 47-year-old patient just presented with restlessness and some headaches, maybe some palpitations. So he was brought to the ER for possible arrhythmia. They thought, what could he have? Neurologically intact, nothing on review assistance except some intermittent lightheadedness. So someone was worried about a stroke. They put him in for a CT, CTA, MRP, and he was diagnosed with this 2.5 centimeter right-sided ventricular tumor and an enlarged temporal horn, which probably caused his lightheadedness. We also had, by chance, the CTA and MRP and CTP studies. So you see it's a homogeneously contrast-enhancing lesion, very hyperperfused with the vascular pedicle inferior, anteriorly, and superiorly to the choroid plexus attachment. So clearly looked like a meningioma to me. What are my options to get in here? Most people on the right side think about right-sided superior parietal lobule access or mid-temporal access. Coming from the top has the advantage of low risk of hemiparesis and little risk of visual field defect. Coming in from the side gives you better control over the vessels, but has a higher risk of a visual field defect and surprisingly a lower cognitive risk on the right side, obviously. So I go in right side superior parietal, image guided plan. You find a short corridor of dissection, and it's rather simple to take this out. Very safe, very familiar, very straightforward, minimal visual field defect. Very different kettle of fish on the left side. So this was a 71-year-old female, also came in with non-specific headaches, recent word finding difficulties noted, non-focal exam, maybe some blurred vision, got a CAT scan in the ER, 4 by 5 centimeter lesion in the ventricle, again an entrapped temporal horn. Here again, we got the CTA showing displacement of all internal vessels to the opposite side, vascular pedicle inferior, vascular pedicle medial superior. And you can see it's sort of a cauliflower lesion that doesn't really differentiate well from the surrounding parenchyma, but on T2, a perfect CSF space around it. So you can expect good surgical planes. I also got tractography because in these cases, it shows you nicely the displacement of the surrounding lesions. And I got a functional MRI scan. The DTI is the relevant study here showing you that all AP fibers are displaced and go around it. There's a beautiful corridor coming in from posteriorly. So you can put this into tumble mode and place it in your image guidance system. I chose a left parietal occipital axis through an interparietal sulcus that gives you a short distance to dissect in the sulcus, only 2 centimeter of white matter dissection. And you basically start from Fraser's point above the ilium towards the left side. Again, safe, very familiar. And coming in from occipital gives you less injury to the left side dominant hemisphere. So this is what we did, 3/4 prone position, come in from almost occipital, so you stay outside the primary, secondary visual cortex, no stroke associated, beautiful resection. Now, post-op management of these patients is not different from any other patients. Some steroids for a few days, antiepileptics, and I get a CAT scan in a few hours and just manage them conservatively day 1. Some of them may bleed, not unusual because you have a fluid-filled space. I picked this up within 3 hours post-op. I don't wait for this to get larger. I just take the patient back to the OR because I think you can clean this out, make sure there's no bleeding, and there's less chance you need a shunt afterwards. Now, this is the special case that I came across, and I want to show you what I learned from the previous 2 cases to do this one. So this was a 47-year-old left-handed woman that came in on call, a bit unusual. She was at an outside hospital. She had a history of Sturge Weber. They told me right away. She had really no other major symptoms and no other history other than anxiety. She came in with a sudden onset of headaches for 5 months, but that evening she decided to go to the ER because it got worse over time. And she had some decline in memory and some falls, so you may argue that may not be related. She came in on exam with a perfectly normal exam, except the hemianopia and all the stigmata of Sturge Weber. Oh, now I need to see how I can... All right, this is also called encephalotrigeminal angiomatosis for a reason. There are malformations from the vascular structures. They are mesodermal and ectodermal. It's not an inherited malformation, it's sporadic, it's rare, it's 1 to 50,000 births, no gender, race predilection, and they have these characteristic lesions of port wine stains in the face and the trigeminal distribution, plus calcifications. There are 3 types, and here we are dealing with type 1, so the facial and leptomeningeal malformation predominates. This is the outside hospital scan she came in with. So large tumor buried in the ventricle, yes, some ventricular dilatation, but there was also this AVM type of malformation overlying it. And I was really stunned because I said, this doesn't quite look the way I remember Sturge-Weber from my pathology textbooks. So I got a CTA. The CTA showed me again large overlying calcified vessels, maybe tram track calcifications. And I just decided to bring this patient in. I didn't feel comfortable sitting on this. So I was worried about the leptomeningeal angiomatosis. Obviously, you go to the literature, you see, does anybody else know about how to deal with this best? There's essentially nothing on the market, 3 other cases ever reported. So that didn't help me much. So I decided, okay, do my usual thing. I get a functional MRI scan, and it showed me the sensomotory cortex just overlying the lesion right next to the vascular malformation, both for foot and lip. And the hand was sort of just abutting the particular tumor surface. We also got speech and language mapping, which shows you the tumor was essentially surrounded by activated tissue. There may be an element of venous contamination in here, so it was hard to tell. So I decided, let's get a CTA with the composite angiogram. We saw lots of venous abnormalities surrounding this tumor. You can see the leptomeningeal anastomoses going deep, which I didn't understand, but maybe that's just the projection. So I decided we need a formal angiogram. On the left side, you see the ICA injection. There's very little happening except the big blush medially with maybe the attachment to the choroid plexus. So I said, okay, I need to study this further. The ECA injection really didn't show us much. You see that there are no collaterals feeding this from the outside. I was just worried about this because I wasn't sure what the malformation would look like. So what is my surgical plan? Well, I think there are 4 steps to optimize surgery. First step is avoid eloquent cortex because you don't want to mess up the left side and you don't know what collateral flow there should be. You want to have minimal retraction. You want to consider your working angles, and you want to have an early exposure of the vessels, especially in this double pathology in front of you. And obviously, I wanted to avoid whatever this weird AVM venous anomaly was on the surface. So I thought first maybe go posterior interhemispheric transfalcine from the opposite side. So just to undermine the left hemisphere. Hard angle for a big lesion, you may not have good extent of disease resection, and you may have more traction. So I abandoned this idea because it usually works better for the posterior lateral ventricle, not so much for this one. Now I thought about transparietal, transcortical. Should I go through conventional superior parietal lobule? Well, it's not so good on the left side, but it usually gives you good access to the atrium. So giving these disadvantages of both approaches, I said, maybe I just go a conventional 3/4 prone Fukushima position and do this image guided based on the surface veins when I open. And I actually think that instinct helped me a lot. It also would give me short dissection through the white matter. I went back to this book by Kano that told me if you have a tumor that is more laterally expanding, go transventricular, don't try to go transcallosal. So this is what we did. I apologize. I had a beautiful video of this, but it got corrupted and it died sort of on me yesterday. This is what we did. We really found between a larger surface anomaly of these veins, a perfect corridor to go into a sulcus, have a 2 centimeter dissection into the lateral ventricle and just create a tunnel. And the vascular malformation on the surface was partially thrombosed, partially just a bundle and tangle of vessels that I had never seen before in this density. We were able to create a corridor getting into the lateral ventricle without taking any of the surrounding vessels. So no DWI associated stroke. We were able to preserve the thalamostriates and even the choroid plexus supply deep and medial to it. And we were able to go through this. This is the post-op MRI scan with a perfect enucleation, I would call this, of this tumor sitting in the ventricle. So pathology, again, was a bit surprising. This wasn't the typical fibroblastic meningioma found in the ventricle. This was one with transitional angiomatous features. So I'm having the sequence right now to see, is there a genetic correlation between the meningioma and the Sturge-Weber disease? The results are not yet back, so I can't report this. But I can tell you this was an atypical meningioma in an atypical location in an atypical patient with dual pathology. So I continue to watch this patient. What have I learned from this case? Dominant left-sided intraventricular meningiomas remain a technical challenge. In the setting of vascular abnormalities, use multimodal approach and don't save on imaging. And here I got the angiogram, which I think helped me a lot to be reassured about not running into major trouble at the surface. This study solidifies that you can do successful surgery in a challenging setting, even if there's no literature on board. And I will continue to watch this patient for surveillance in the future. Thank you so much.
Thank you very much.
Der Wundschmerz 2 Tage und dann ist der Schmerz ab.
Actually, guys, could you mute yourself? Very good. Yeah, it was a as you summarized, unusual case in an unusual case, and clearly very challenging one. Any comments? Questions? Ramesh.
I think it's a very interesting case. My only comment is that it is so fortunate that it was not a proper AVM on the surface.
Yes, absolutely. I was really worried about the technical challenge to deal with both at the same time. Because I'm not the most skilled vascular AVM surgeon, but I asked my vascular colleagues to be available, and we looked at the surface of the brain, and it looked very different from what we saw on scans. So that was also a good teaching moment for us. Despite the angiomatosis of the leptomeningeal part, there wasn't a big arterial supply to this. So it was largely venous dilatation. Because of the calcifications, I think there was a lot of collateral flow, but we were able to find a lucky sulcus to go through.
Now I know Ramesh has both interest in intraventricular tumors, including meningiomas. Is quite dark in his room, so I'm not sure whether he's sleeping or still with us. And also, any comments, Ramesh?
This was brilliant, really brilliant planning. Was great. No one can fault your approach. It was really the ideal approach for this particular case.
Yeah, I also enjoyed the fact that, or was glad you highlighted the choroid vessels. Pretty much everybody knows about the circle of Willis, but very few people know or talk about the C circle. I call it C circle because it's not only it is C-shaped around the C-shaped choroidal fissure, but also it has various C arteries feeding it. And it's not just one artery that if we take care of it, we've taken care of blood supply to a tumor, but there are quite a few of them. It is the anterior choroidal artery from the ICA. There is several lateral choroidal arteries coming from the PCA, and then there is the artery that winds around the brainstem, going through the ambient cistern and quadrigeminal cistern, enters the velum interpositum into the third ventricle, and they're all connected as collateral circles. So if we have a large tumor sitting in the atrium, such as meningioma or perhaps even chorioplexus papilloma in a child, we need to be very much aware of how to turn off the taps before the whole tank will be empty. Yeah, it was a great case. Any other comments?
Is anyone
Imad,
on the panel?
Imad, you need to actually, before Imad goes, Egg has a comment, but then Imad, yeah.
I want to ask whether anybody would write this from the opposite side, going transfalcine, because, you know, I read about it. I've done it before for 2 other lesions, but not in this setting. Would have anybody chosen a different way to get in, or everybody thinks this is like the one option? What do you think, Imad?
I think the one and only, this is the approach I will use. But my question, perhaps Henry is there? Is he with us? Henry? I'm just wondering, do you see any value having an endoscope for visualization to see these feeders away from you?
So
not for the procedure, but for visualization.
I'd say during the case, once you've done a significant amount of debulking, using the endoscope to look beyond the tumor to see where is the real attachment, is there another vessel from the choroid plexus coming into the tumor, maybe below, that would be helpful. I wouldn't stick a endoscope in from a second angle, because then you get dual injury to the dominant hemisphere. And I'm always afraid of, you know, the left side is so much more sensitive to any traction injury or any minor bleed. I want to minimize my exposure of white matter. So I personally wouldn't do it for a tumor as big as this. But if you have a smaller tumor, by all means, endoscopy may be the better way to go, right? But once the tumor is the size of a tennis ball, I think endoscopy is not my choice.
I completely agree.
I'm not talking about endoscopic resection. I'm talking about visualization as a hybrid use of the endoscope.
Yeah, maybe Henry can comment on this. He's back on board here.
No, I think in such a large tumor, you are right, there is no space to bring the endoscope in. You have to create some extra space. You know, of course, you can retract. Sometimes we retract tissue and then we go in the space with an angulated scope to look around. But I think in this large lesion, the effect or the benefit of the endoscope would only of minor importance. But in smaller lesions, or when you want to look around the corner, it's really nice to have the endoscope in.
Yeah, I think so, right?
I agree.
But he mentioned one point, I think Eckert, just one thought. He mentioned after debulking of the tumor, he wants to see the source of the feeders.
Yeah, that is, if you have space, then of course, if you have space, it makes sense to look with an endoscope around.
Yeah, and I agree with Imad. You know, endoscope allows us simply to look around the corner, and the companies, I don't want to mention any particular companies here, but they make it easier for us, particularly having light endoscope that we can just hold in our fingers, or perhaps fix that. So sometimes knowing what's behind the corner, and particularly when there's a big ball, so obstructing vessels may be helpful. So I agree there.
Is
and
Giovanni
we
still
use
on the
endoscope quite a lot, actually.
Is Giovanni still on the call? Would you have used ICG just to get a better idea about the vascularity here? That was I was impressed about Giovanni's presentations in the last few weeks, showing his use in, you know, tumor cases to use ICG to see venous collaterals or venous flow. Can you briefly comment on that?
Well, ICG, I think, is helping you to see what are the feeders of the remnant. And the advantage of ICG is that you can use step by step. If you are using fluorescein, that for meningioma is not the case, but is the case for AVM, you only use once during the surgery. So it's a tool, you know. It's like to have the endoscope make a endoscope assisted microscope. I think that when you have such a huge case, a huge tumor, I think that is and with what you studied in advance of, that means this kind of feeders, and so you have to have available for an anesthesiologist to inject it.
Yeah. Okay.
Yeah, I think here the key really is angiography, because this can show us where the main feeders come from. We know that there will be on the other side of the tumor from the atrium, that's for sure. But in terms of which are the prominent arteries, i.e. which side of the tumor we should focus on first, this can be helpful. One thing that is often not helpful is consideration of embolization, because the choroidal arteries are usually too small for the radiologists to enter. Different thing is perhaps in pediatric tumor, when we have large choroid plexus papillomas, then the negotiation is more important. But in adults, usually I haven't come across a case that the neuroradiologist will be happy to stick a catheter into.
Thank you.
This was an excellent case, but actually we have like 18 or 19 of these lateral ventricular meningiomas. And you said that yourself, that the only treatment is surgical. There is no other option should you need to operate on the case. And once you get, we never used another approach than you did, exactly the same thing. And you always come from the opposite side than the feeding arteries are. But you simply must deal with them. That's there is no other option. Since you start resecting the tumor, you cannot quit in half, or you cannot leave some piece behind. So you simply go through as long as you hit the feeding arteries. And what I usually do, that I coagulate the whole plexus in the region. You are posterior to all the important arteries, so it's always rather easy and good management of the feeding arteries, the whole plexus.
Yeah.
Okay, so if there are no burning questions, I would like to hand over the leadership of the session to Victor. Victor, are you with us?
Yes, thank you so much.
Yes. Victor, before you start, please let me say goodbye to everyone, since I must leave. Gentlemen, it was fun, and it was really one of the best meetings we have had. Bye-bye.
Bye-bye, Vladimir. Stay safe.
Bye, Vladimir. So we're moving across the Atlantic now to Mexico.
Oh, yes, we are planning to have a Congress, but now COVID is too bad in Mexico. We were planning to make a Congress in Acapulco next July. So it depends of the COVID disease, of course.
Well, we're delighted. We're delighted to.
You all are invited to come in with us. Yes.
Well, thank you very much. Well, in the meantime, we can join you in your room in Mexico via Zoom.
Acapulco is really a beautiful place to know. Yeah, but you should stay here if we do this Congress at least 1 or 2 weeks to enjoy this beautiful place. Yeah. So you all are invited. So now we have a lecture from Dr. Matias Baldoncini. Dr. Matias Baldoncini is really a leader in Latin America in skull-based vascular and also peripheral nerve surgery. Now he's going to present left frontal AVM involving the Broca's area and precentral gyrus. Dr. Matias Baldoncini is also a head of microsurgical neuroanatomy lab in Buenos Aires, Argentina. Thanks, Dr. Baldoncini. Go ahead.
Hello, everybody. Can you hear me?
Yes, we can. Yes.
Okay. Happy to see you, everybody. Thank you, Thomas, Victor, Imad, and Vladimir, and all my friends of this great anatomy committee of the WFNS. I am very happy to be here again in this special webinar honoring his lifetime achievement of Professor Yazargil. For me, it's a huge pleasure. And the lecture is related to the complex case that we have 2.5 years ago in our neurosurgical department in San Fernando Hospital here in Buenos Aires, with a young patient who presented a left frontal AVM, a huge frontal LVM in the left hemisphere, of course, involving not only the superior, middle, and inferior frontal gyrus, but the AVM involves the presental gyrus too, and of course the Broca's area in these patients. This was a young woman, and he is an artist, and he loves to paint realistic paintings. And he presented to our service when she was 29 years old. He presented a history of seizures treated with phenytoin and oxcarbamazepine, and she was diagnosed 10 years before to the first bleeding. She was diagnosed with the AVM Spetzler-Martin classification, grade 5. When the patient was received in our emergency room, the CT scan shows a big intracerebral left frontal hematoma with a small blood clot inside of both lateral ventricles, and in the third ventricle exactly the same. The patient was awake at the emergency room with the left hemiparesis and some difficulties with the normal speech. When we perform an angio-CT, in that moment, we observe a big AVM and compact nidus in the left frontal hemisphere, laterally to the intracerebral hematoma. It was a big intracerebral hematoma. We can observe here the three-dimensional reconstruction of the angio-CT in the first day that the patient was received at the emergency room in our hospital. We can observe a big left frontal AVM with some big venous of drainage arising in the superior and in the inferior pole of this big frontal AVM. We decided to perform a cerebral angiography that this study informed us a left frontal AVM with 6 centimeters of maximum diameter, with afferences from the anterior cerebral, middle cerebral artery and bilateral anterior cerebral arteries, and some afferences from the posterior circulation using a left posterior communicating artery that was fatal in this case. We can observe here the preoperative angiography, of course, where we can observe that the AVM resides from both anterior cerebral arteries, from the left middle cerebral artery too. It's a big compact nidus with 3 important drainage veins which drains the venous blood of this AVM. We can observe here that from the medial border, the AVM receives 1, 2, 3, and 4 branches from the contralateral and homolateral anterior cerebral arteries. In this lateral projection, we can observe a left carotid artery injection of contrast, of course, and in this segment of M2 in the left side, we can observe 1, 2, 3, and here we can observe an artery that was an artery in passage, giving before to passage the nidus 3 or 4 small branches to the nidus, as we can observe in this projection. Here, another lateral projection, and we can observe here this precentral artery that was in this case an artery in passage. We know that the artery, the in passage artery, we need to preserve it in order to avoid to produce ischemia, especially in this case, because this artery are vascularizing the precentral gyrus in the left side in this case. Another projection, and here we can observe an injection of contrast in the right vertebral artery, and we can observe here that the AVM using a fetal posterior communicating artery is using some part of the blood from the posterior circulation in order to fill this big nidus. We can observe here a posterior communicating artery in a fetal configuration that reach to the inferior pole of this AVM. Here, this is a lateral projection in order to observe this hemodynamic event. It is important because it's a high flux AVM. This is important to analyze when we have to deal with this kind of vascular malformations, the draining vein, because we know that if the nidus have 2 or 3 big draining veins, the possibilities of bleedings are low. And of course, you need to observe if the AVM presents arterious or venous aneurysms, because we know that the possibilities to bleed are higher in patients that present intranidus aneurysms. We can observe here a posterior drainage vein and an anterior drainage vein, both of these big veins draining to the superior sagittal sinus. And here, this vein divides in two ramus. The superior ones going to the superior sagittal sinus, and this one going to the sylvian fissures, and then an anterior ramus to the sphenoparietal sinus, a posterior ramus using the vein of Lavey draining to the transverse sinus in this case, and we can observe colored in blue in this lateral projection. This is the analysis of the pattern of the venous drainage of this big AVM. Here, exactly the same in the lateral, in anterolateral projection, the posterior drainage vein and an anterior draining vein to the superior sagittal sinus, and here the inferior drainage vein going through the cavernous sinus using the sphenoparietal sinus and draining to the transverse, left transverse sinus in this projection. Okay, this is the MRI of the patients. We can observe the close relation with this blood clot with the medial border of the AVM in the planning of the surgery. If we decide to perform a surgery. This relation is very important in order to recognize that we have not AVM medially to the blood cut. This is an important pathological landmark if you need to deal with this kind of pathology. Here we can observe the compact nidus in close relation with the Broca's area and the motor cortex of the left hemisphere of the brain, as we can observe in this MRI in the preoperative study. Here we can observe the inferior pole of the AVM here involving part of the Broca's area. Here is the inferior frontal gyrus. This is the orbital part, the triangular part, and the opercular part is here in close relation with the inferior pole of the AVM. And here is the precentral gyrus, the primary motor cortex of the left hemisphere, here in close relationship between the AVM and the motor cortex of core. The coronal section we can observe exactly the same, the compact nidus, medially the blood clot, and in this patient we decided to perform a tractography in the preoperative period, and we observed that the corticospinal tract was displaced medially to the blood clot. Here we can observe that the blood clot is medially to the corticospinal tract. And now, 3 months after the bleeding, the patient was without deficit, only with weekly seizures with transient right arm monoparesis. And now, in that moment, we perform several meetings in our department in order to decide the best option for this patient, to operate or observe. Remember that the patient was 29 years old, female. The natural history of untreated AVMs, we know that the risk of bleeding from untreated AVM is from 2 to 4% per year. It is greater if in the first 5 years when presenting symptoms, like in our case. In patients with a history of previous bleeding, we can observe in literature that are reported a percentage so high like 44% of bleeding annually in patients with previous history of bleeding. And of course, if the patient had a history of bleeding plus seizures, the risk of rebleeding is 23% per year. In the classification of the AVM, we use the classic classification. The patient had a 6 centimeters AVM, 3 points, in an eloquent area, of course, because the AVM were close to the Broca's area and to the motor, to the cortical motor primary area in the left side, 1 point. And in this classification, the AVM have not deep bleeding drainage, only superficial drainage. 4 points in the Spetzler-Martin classification AVM. We know that during pregnancy in this case, as I presented, it was a woman, the maternal mortality after bleeding can reach 40 to 50%. And in AVM diagnosis during pregnancy, 85% will bleed during pregnancy, especially in the 7 or 8 months of pregnancy. After several meetings in our department, we decided to operate the patient 5 months after the first bleeding of the AVM. We perform a standard frontotemporal craniotomy with a slight extension posteriorly here, as we can observe in the skin incision, with neurophysiological monitoring during the whole surgery in order to perform the mapping of the cortical and subcortical function, especially of the motor function, of course. For this big AVM, it's very difficult to obtain the speech function because there are long surgeries, and you know that if we perform an awake surgery, the patient can help us during some times of limited of time, during a half an hour or an hour, and this surgery is not an hour surgery. Here, sorry. Here we can observe the cortical exposure after the durotomy. Here we have the superior frontal gyrus, the middle frontal gyrus, the inferior frontal gyrus, of course. This is the nidus of the AVM. Here is the Broca's area, the primary motor cortex of the left AVM, and here in blue, with blue colors, the two superior drainage vein of the AVM. Here we can observe a small tail of cortex of the primary motor cortex here under this vein, and the inferior drainage vein, this one going to the sphenoparietal sinus, and this one going to the transverse sinus using this vein, that is the vein, the Laves vein. We performed this surgery with two colleagues. We were working during 27 hours with these patients, performing the monitorization of the cortical functions. Here we obtain motor response, for example, monitoring the cortex, the superficial neuromonitoring functions and the subcortical too, in order to preserve the corticospinal tract intact with this monopolar stimulation, and of course with these cortical grades, in order to localize in a perfect way the region where the motor functions is represented in this cortex. Of course, during all the surgery, we operate this patient using this neuromonitoring assessment, and this was why the surgery was so long too. And this is the final view. We can observe the complete removal of the AVM. This is the pathological piece of the AVM of 6 centimeters of diameter. And this is the angiography in the postoperative period, where we can observe several clips in the place where the MAB were located. And we observe a normal angiography with the field of the AVM, without AVM 1 month after the surgery. The patient evolved with a slight hemiparesis that recovered completely 2 months after the surgery, and during 1 year the patient needs to go to a phonoaudiologist in order to practice some words and recover his speech, her speech completely. And this is the video that I recorded last week, because the patient came to the hospital 2 years after the surgery. I asked to her, please, you can elevate your left arm, your right, please. Yes, excellent. What's your name? She says her name. How do you feel? I asked to her. Fine. Very good. Very good. Okay, and this is the end. Thank you very much for your attention.
Thank you, dear friend Matias Baldoncini. It was a really good case, an excellent surgical procedure. Do anybody have some question or comment, please?
I thought it was an excellent case. I think the planning and the final execution of the surgical procedure, defining all the arterial and the venous angio-architecture was excellent. So I think well done. There's nothing more really to comment on it.
Thank you, Ramesh. It was a difficult case for us. We wrote to two neurovascular surgeons who told us, please leave that the ABMs makes damage, not you. And we decided to perform the surgery in close contact with the patient, with family, because we know that these complex cases are really difficult to obtain a surgery without any deficit. And it was a difficult case.
Agree.
Yeah, Matias is always very meticulous in his thinking and in his doing. So, you know, I'm not at all surprised that it all went so well, and the illustration and demonstration of it was beautiful. Well done, Matias.
Thank you very much, Thomas.
Well, compliments for this very difficult case and for the courage to do surgery. And I think that you did really all you need for avoid any problem after. The surgery of EVM is always a question mark. Also, what are looking simple become complicated and vice versa. Only suggestion, if you have another case, use the fluorescein because after Eric Gadol and our experience, is very useful to see the feeders when you start surgery. That's it. Compliments again.
Thank you, Professor Giovanni. Absolutely agree with you. Unfortunately, as you know, we work in a developed country, and it's very difficult for us to obtain fluorescein. Only in the private hospital we can obtain it and use it for our patient. Unfortunately, this patient was operated in the public hospital, and we have not so many resources. Thank you very much, Professor Giovanni. It was a hard work. We operate, as I told you before, we operate this patient with 2 colleagues. We were working during 27 hours, and I think that if you need to, this is my suggestion for especially for young neurosurgeons, if you need to deal with this pathology, I suggest that not operate the patient alone. You need to operate without other colleagues because you need to work many hours.
Victor?
Yes, Dr. Ahmed.
Yeah, I have one request from you, Matthias. If you give a few words about the team approach with a neurologist and an anesthetist, because if you are doing some of these cases awake, you need them very badly, and you need to do the rehearsal with the patient ahead of time, which is very important. Perhaps you might comment on this one.
Yes, Iman, as I told during the lecture, here is Fernando Martinez, a close friend from Uruguay. He has a lot of experience with awake surgeries, and what we learned with awake surgeries in our small experience is that the patient collaborate with us during a close time. We can't operate a long surgery mapping the broadcast area because the patient will not cooperate the whole surgery. And of course, agreeing with Ahmad, we need to work with an excellent anesthesiology team, and of course with the neurophysiological team equally for this kind of complex surgeries.
Thank you.
I think, yeah, important the anesthesia, because we kept the patient like full anesthesia or almost full sleep up to the moment where we want to tackle that AVM. And this is the time where you will cut short on the time the patient exposed to be awake and communicate with you. So this is where some anesthetic material has to be considered, that you won't lose the patient completely knocked down, but does not feel the pain and eventually can cooperate. Thank you.
Yes, Ahmad, thanks.
Well, thank you, Matthias Baldroncini. Now we continue with Dr. Professor Fernando Martinez from Uruguay. He is a member of the Committee of Peripheral Nerve Surgery from World Federation of Neurosurgical Societies. He is also coordinator of Peripheral Nerves Pathology Unit in Montevideo, Uruguay, and he's going to present us brachial plexus dissection. Thank you, Dr. Fernando Martinez.
Thank you very much, Victor Hugo. I will speak slowly because English is not my mother language. And I will center this lecture in anatomy, in surgical anatomy, and based in 3 cases. 2 cases of brachial plexus trauma and 1 case of brachial plexus tumor. So what is the importance of surgical anatomy? Obviously, it allows us to make safe and fast approaches, help us understanding the clinical picture of our patients, and for me is an invaluable tool to avoid complications. If you know surgical anatomy, you know in which places are the structure that you need to respect. Specifically for brachial plexus approaches, the causes of brachial plexus approaches are trauma that can be open or closed. 90 to 95% cases of trauma are closed trauma. We also can approach the plexus because of tumors in the plexus itself or around the plexus, in compressions of the brachial plexus like thoracic outlet syndrome, and in iatrogenic lesions of the brachial plexus. And this picture shows us that brachial plexus is located supra and infraclavicularly. And look at this. Here we can recognize the spinal nerves that forms the brachial plexus, C5, C6, C7, C8, and T1. The spinal nerves forms the trunks of the brachial plexus, superior, middle, and inferior. And we can locate spinal nerves and trunks over the clavicle, up to the clavicle, and divisions of the trunks and the cords are located behind the clavicle. So if we must to approach spinal nerves or trunks, we must to access the supraclavicular plexus. And if we need to approach the divisions, trunks, and terminal branches, we need to approach infraclavicular plexus. Here we can see a supraclavicular approach, and here we can see a supraclavicular and infraclavicular approach. This approach gives us a good view of supraclavicular and infraclavicular brachial plexus. This is a picture of the supraclavicular approach, and this is a cadaveric picture of a supraclavicular and infraclavicular approach. Here we can see superior trunk, middle trunk, inferior trunk, the clavicle, the pectoral muscles, and the infraclavicular plexus. This is a huge approach to the plexus, but the brachial plexus trauma are not really a brachial plexus injury, but is a radicular avulsion. For this reason, in most cases, we found this kind of lesion. This is the spinal cord, posterior nerve, anterior nerve, spinal nerve with the ganglion, and most of the lesions in brachial trauma are located here in the preganglionic region of the spinal nerve. Also, we can find postganglionic lesions and lesions of the plexus itself. And also we can find combinations of these kinds of lesions, but in more than 90% of the cases, the lesion is located here in the preganglionic nerve. We can observe here the spinal cord and the intradural part of the spinal nerves. The ganglion is located here, and most lesions of the brachial plexus are not properly brachial plexus lesions, but are spinal preganglionic nerve lesions. This is the MRI image of a brachial plexus injury, the preganglionic brachial plexus injury. In this side, we can observe the normal nerve, and in this side, we can observe the pseudomeningocele going through the neuroforamen. We can see here cerebrospinal fluid, but not nerve. And in this MRI, we can also see the same. Here is the brachial plexus. Here, cerebrospinal fluid in the location of the brachial plexus. So this is the most frequent pattern of brachial plexus lesion. So I will speak today of supraclavicular approach because it allows to solving 90% of cases of brachial plexus lesion. If you dominate the surgical anatomy, it's easy and fast, and it has very clear surgical step that we will see today. First step, position. The patient must be located in dorsal decubitus with a small roll under the shoulder and the head slightly lateralized to the opposite side. This is the surgical position. A small roll under the shoulder. Here is the neck, the shoulder, the chest, and the head slightly rotated to the opposite side. We can identify here the clavicle and the sternocleidomastoid muscle, and here the trapezius muscle. These three structures are the main clue to the approach: the clavicle, the sternocleidomastoid muscle, and the trapezius muscle. We can see here sternocleidomastoid muscle, the clavicle here, and the trapezius muscle here. And this is the supraclavicular triangle. The incision is located 1 centimeter above of the clavicle here. First steps are skin incision, platysma muscle sectioning, recognition and preservation of external jugular vein, and superficial cervical plexus. This is a picture taken from the book of Yusa, in which we can recognize here the sternocleidomastoid muscle, trapezius muscle here, clavicle here, and the supraclavicular triangle here. This is the jugular, external jugular vein, and these are the branches of the supraclavicular branches of superficial cervical plexus. This is a picture in which we can see here the suprasternal branch of the cervical plexus, supraclavicular branch of the cervical plexus, and supraacromial branch of the cervical plexus. So let's see this in a surgical case. This is the patient in the position, the shoulder, the chest, the neck. So this is the incision and the recognition of platysma muscle here. We must section in platysma muscle, and we start to identify these branches of superficial cervical plexus. With more detail, platysma muscle, we cut the platysma, and we find branches of superficial cervical plexus. We identify and put a vessel loop to retract the branches of the cervical plexus. Next step, second step, recognition of homoioideus muscle and sectioning of the muscle, recognition of transverse cervical vessels, and supraclavicular fat. Here we can identify with the blue vessel loops the branches of the cervical plexus, and here the homoioideus muscle that crosses over the brachial plexus. To expose the supraclavicular triangle and to locate the brachial plexus. With more detail, again, I put a stitch here, and I put stitch here, and I cut the muscle here. In this picture, we can see one stitch here, one stitch here, and the muscle is cut. The brachial plexus is located here under the muscle, and the transverse cervical vessels are located here under the muscle and over the brachial plexus. So if we can identify the homoioideus muscle, the plexus is very close. Here, we put a vessel loop around the cervical transverse vessels. So the superior trunk of the brachial plexus must be here. So next step, identification of brachial plexus, anterior scalenus muscles, and phrenic nerve. This is a case of a tumor of the lower trunk of the brachial plexus. So this is a picture of a normal superior trunk. We can identify here C5, C6, superior trunk, and C7. Because my target was the inferior trunk, I do not dissect the final part of the superior trunk. We will see this in a case of trauma. That's the case. This is homoioideus muscle. In this case, I don't cut the muscle. Here, the anterior scalenus muscle, and here, the superior trunk. I dissect the final part of the superior trunk, and we can identify here superior trunk, suprascapular nerve, anterior division of the superior trunk, posterior division of the superior trunk. So supraclavicular approach gives us a very good view of superior trunk, middle trunk, and the terminal part of the superior trunk. We continue with the normal brachial plexus. C5, C6, superior trunk, C7. We continue C5, C6, C7, C8, T1, and here we can identify, but not so good, the inferior trunk. Supraclavicular approach gives us approach to all of the trunks of the brachial plexus and also to the inferior trunk. We can operate on at thoracic outlet syndrome by a supraclavicular approach. Let's see what we do in surgery. We need to identify the trunks and the spinal nerves. This is the simulation of the superior trunk. We will see this in a better way in a few seconds. This is the stimulus of C6 superior trunk. We can see the flexor response in the elbow. We can see the movement of the hand, obviously. And we will stimulate the lower trunks. And what we see is the flexion of the fingers. We will see this in a few seconds. This is T1. Okay, so anatomy is a guide, but neurophysiology gives us the confirmation of the anatomical structures. And one of the most popular techniques in brachial plexus surgery is neurotization of suprascapular nerve with spinal accessory nerve. So by supraclavicular approach, we can approach the spinal nerve. This is the supraclavicular approach. Here we can see the platysma muscle, external jugular vein. Here, homoioideus muscle, retraction of homoioideus muscle, identification of the phrenic nerve, anterior scalenus muscle, so brachial plexus must be here. Anterior scalenus muscle, the phrenic nerve with a vessel loop here, superior trunk, homoioideus muscle retracted, superior trunk, posterior division, anterior division, suprascapular nerve, and homoioideus muscle. So remember the location of suprascapular nerve here in relationship with homoioideus muscle, and look the location of the accessory spinal nerve. Suprascapular nerve is located here. Spinal accessory nerve is located here. It's allowed us to give, perform a neurotization from spinal to suprascapular nerve. Okay, tips and trips in my experience. In some cases, the location is hard to locate the brachial plexus because trauma modifies the normal anatomy. So one important point is the brachial plexus is located in the interscalenic triangle. And the phrenic nerve is located over the anterior surface of the anterior scalenus muscle. And this is the tip. C5 frequently give a small branch to the phrenic nerve. So if we follow the phrenic nerve from anterior aspect of the scalenus muscle to C5, we can find C5. This is a very interesting case I published in the Argentinian Journal of Neurosurgery. This is the clavicle, sternocleidomastoideus muscle, trapezius muscle. Here is the supraclavicular triangle. And look here. This is the anterior scalenus muscle. This is the phrenic nerve. And this is an accessory scalenus muscle. I look for the brachial plexus and I didn't find the brachial plexus. So I used the phrenic nerve as a guide to the brachial plexus. I identify here anterior scalenus muscle, here the phrenic nerve, and I follow proximally the phrenic nerve. So I merge inside this accessory muscle. And in this picture, we can see anterior scalenus muscle, the accessory muscle resected, and the brachial plexus here, and posterior scalenus muscle here. So again, the tip is, if you can find the phrenic nerve, you can follow this proximally until you find C5 root. Dangerous structure to avoid complications: subclavian vein that is located in front of the inferior trunk. So if we need to operate superior or middle trunk, subclavian artery is located in a safe position. Look here, phrenic nerve, anterior scalenus muscle, and phrenic nerve guide us to C5, C6 superior trunk. We must be aware of this variation, 1 and 2 phrenic nerves. Lucas published that we can find this disposition of the phrenic nerve. That means 2 phrenic nerves that can be unit in the thorax in 60% of individuals. And finally, this is a variation that is not, we can find a lot of publications about these variations, and I found this in 2% of cases. That is a high subclavian vein. This is a supraclavicular approach. This is the clavicle, and here we can see the subclavian vein. Superior trunk is located here. Here is the superior trunk, and this is highly placed subclavian vein. You must be aware of this variation that is 2% of cases in my experience. If you go to superior trunk, this approach is safe, but you must be aware of this variation. If you go too fast and you don't identify this variation, you can injure the subclavian vein. So thank you very much for your attention, and I am here for the questions.
Thank you, dear friend Fernando Martinez. If anybody have some question, some comment,
or maybe comments, I hope.
I have heard, friend Fernando, that surgery of peripheral nerves has to be made by plastic surgeons, and other professors think that this kind of surgery has to be made by neurosurgeons. So I think both specialties can do that surgery. What's your opinion about that in your country?
I agree with you. In the world, the leaders of peripheral nerve surgery are neurosurgeons, like Mario Siqueira from Brazil, like Martin Malesi from Holland, David Klein from the United States, Lucas Rasulic from Serbia, a lot of my good friend Mariano Sokolovsky from Argentina. A lot of neurosurgeons do a high quality peripheral nerve surgery, but also plastic surgeons made a high quality brachial plexus surgery, and also the orthopedist. Because, for example, in Mexico, I don't remember the name. He's a very close person, but I missed the name in this precise moment. But a very close friend from Mexico is orthopedist, and he made a high quality surgery of brachial plexus. And also, yes. And also Jaime Bertelli from Brazil, he's orthopedist and made a high quality brachial plexus surgery. So I think the three specialties can perform brachial plexus surgery.
We want to keep it under the umbrella of neurosurgeon.
I completely agree. I think that the nerve belongs to neuro and not others. So we have to defend our field.
I want to make a comment.
But to be honest, you know that carpal tunnel syndrome is the example that is done by general surgeons, plastic surgeons, hand surgeons, orthopedic surgeons, neurosurgeons. I think there are only 1 or 2 surgical specialists that are not operating on a carpal tunnel syndrome, which is actually not really nerve surgery because it is you opening a ligament. But the same is with the ulnar nerve. That's also done by other specialists. Personally, and of course, Giovanni, I fully agree with you. I strongly believe that peripheral nerve surgery should be part of neurosurgery. Nevertheless, for the patient, the result counts. So if somebody has specialized in that and coming from another field and does really excellent surgery for the patient, it doesn't matter. If something is written on his head as neurosurgeon or the surgeon, doesn't matter to the patient so much. It's about the result. And yet I would say that if I have to train residents, I really want them all to learn peripheral nerve surgery. They all come in and want to be either complex spine or vascular or oncologist, but peripheral nerve is a very grateful part of our specialty.
No,
I agree.
More clear the comment. I think that any kind of surgery has need a clinical indication. I wonder if a plastic surgeon can do a clinical indication for a plexus lesion. So I don't say that technically they can do everything. So possibly we can do cataract on the eyes, but who gives the indication? I think that if I operate on my idea, this I make a lot of blind people. So,
Giovanni, you know that synostosis is also operated by maxillofacial surgeons and plastic surgeons. Babies with craniosynostosis. That's same, or it is a team effort. Very often it is a team effort. And personally, for me, that is the ideal situation. The same in complex spine. I really prefer working together with an orthopedic surgeon with a lot of biomechanical knowledge. And he trusts me to deal with the spinal cord. So that's a 1 in 3 situation for me.
Can I make a comment?
Yeah.
Dr. Turel is with us. Please let Dr. Turel have a comment, please. Victor?
Yeah, Keki Turel.
Yeah, hi.
Go ahead.
Thank you. So, thank you very much. Actually, a neurosurgeon is good at the primary part of the brachial plexus surgery, but secondary reconstructions will require a plastic surgeon. So there is a brachial plexus surgery by itself is a specialty. Not all neurosurgeons are aware of the intricate anatomy of the brachial plexus. It also requires a special application of your anatomical knowledge. You asked 10 neurosurgeons, hardly 1 or 2 neurosurgeons may know the anatomy of the brachial plexus as well. So it is, whereas there are some, so therefore I would call it as a brachial plexus surgery is a specialty in itself, and it could be practiced by neuro or plastic, very rarely orthopedic, though Seddon, one of the masters of plastics of peripheral nerve surgery, was an orthopedic surgeon, Seddon. So over the years, several people have evolved, but I think, and as Andre said, it is a good idea to have a teamwork. So when I do a brachial plexus, I'm doing a lot of brachial plexus myself. I do involve the plastic surgeon so that he is there for the follow-up of secondary reconstruction procedures.
Thank you. The best example worldwide, Professor Melisi. I think
yes,
Giovanni knows Professor Melisi, and he was an avant-garde in peripheral nerve surgeries.
Yes.
And he was not a neurosurgeon, I think.
No, he was
a plastic surgeon. He was a plastic surgeon.
He was a plastic surgeon in Vienna.
Yes. Yeah, he trained Majid Sami for brachial plexus.
Yes.
But one thing I want to go back to the point Giovanni mentioned, and I have to respect this one. We are not encouraging the young generation to go into this field. That's why it was lost to the plastic and orthopedic. I still prefer a neurosurgeon trained in this to be the primary on this issue. But we are not training them, and they are not encouraged. For them, it's skull-based surgery. I want to be skull-based surgeon. I want to be vascular surgeon. Now, even vascular, we are losing partially of it with the hybrid, and the hybrid is a question mark because some of them, they are not knowing where they want to go, whether they go into vascular or into surgical vascular. So, and the same with the peripheral nerves.
Yes.
In fact, peripheral nerve surgery has the best results for a neurosurgeon. There is no mortality practically, and there is very little, and the results are astounding. The results of peripheral nerve surgery are very, very superior to any kind of neurosurgery, I would say. Wonderful results.
And the same context what Giovanni mentioned, you don't look at it in one facet. You look to this as a comprehensive management of this case. Even craniosynostosis with Godrich and I forget the name from France, Tissier, plastic surgeon who initiated the craniosynostosis, but who is doing the follow-up and checking the mental performance of these people. I think neuro should take a lead with the help of others if we don't have the enough number.
Thank you.
Thanks.
Thank you. If there is no any question, we continue with Dr. Jeyaretna Sanjeeva. He's going to speak us about hypervascular vestibular schwannoma. Professor Jeyaretna is a lead for the Oxford University Hospital's skull-based surgery program. He completed postdoctoral research at Massachusetts General Hospital and Harvard Medical School. And now he is co-director of the Oxford Skull-Based Surgery and Neurovascular Fellowship. Thank you, Dr. Jeyaretna, to join us. Thank you so much.
Thank you very much, and thank you for the kind introduction. Can you see my screen okay?
Yes, but it is not in slide mode. Yeah, now it's well. Perfect.
Great. So and sorry about the change in program in my talk up here, but thank you very much for allowing me to do that. It's been a great couple of days. I was just so impressed with all the talks yesterday and today, and I hope you'll find this interesting as well. So I want to talk about a sort of a variant of vestibular schwannomas. So, so obviously a lot of very experienced vestibular schwannoma surgeons here on the panel with me today. And these are some of the types of vestibular schwannomas we see. None of these are the variant that I want to talk about today. And for most of us, although it can be challenging, it's a relatively straightforward procedure, getting a good resection, protecting the facial nerve in a vestibular schwannoma. You don't expect a lot of intraoperative bleeding, and even if there is, you can manage it. And historically, although I don't routinely do angiograms on them, but on people who do, they consider this a sort of hypervascular tumor. But I want to talk about a subset of these tumors, hypervascular, very vascular vestibular schwannomas. There's not a lot in the literature about it. It was a very good series that came out from Michiro Kono's group, the Japanese series in 2017. But we've known about this again from mainly Japanese papers, first talking about this back in 1986, where they talk about a high concentration of these vessels, and the key feature is rapid shunting of blood through these vestibular schwannomas, and the shunting or the vascularity can be so great that they actually, a lot of these papers, like you can see the paper at the bottom left, talk about staged surgery. They tend to be quite large tumors. They tend to be younger tumors. In my small experience, I don't think they're related to NF2. We're a large NF2 center here in Oxford, and I don't believe that these are actually NF2 related. They tend to be solitary vestibular schwannomas in young patients. This is a nice description I took from the Tokyo group, just talking about the different types. And really the ones I'm going to talk about are the sort of type 2B, which is the most complicated. So you're looking at this large blush, a rapid blush, because of the shunting of blood both from the vertebral basilar system and the external carotid system. And the 2B type is the complicated type. Even the experienced Tokyo group talk about staging those operations because of the rapid shunting of blood and high vascularity from both the vertebral basilar system and the external carotid artery systems. And this is just a selection of some of the cases over the years that we've had, with some unfortunately with very, very poor results. So the main case I'm going to talk about is this 24-year-old. You can see they're all very young. So we've got a 24-year-old gentleman, a 21-year-old lady, a 19-year-old lady. They're all very young. They all have large tumors. This one, I'll show another picture. It's about 4.5 centimeters. It's even slightly larger than that. They're all large and extremely vascular. And really the result we're looking for is like this case here, where there's only a very tiny bit left behind to protect the facial nerve. She's got a very mild facial palsy that I expect to improve. And occasionally you have to end up staging it, a bit like the case I'm going to show today. So in the 24-year-old gentleman, where we've got a good debulking, but nobody would leave that much residual tumor, particularly in a young patient. There's a reason why I had to stop at that point. His facial nerve is still intact. And this is probably the first patient many years ago, which unfortunately has had a very poor result and has failed surgery and radiotherapy, has a facial weakness and lots of other neurological problems. And actually when Emad asked about talking about cases, what would you have done differently? I thought about this one and how it's influenced all the future cases we have done. So I'm going to focus today on talking about this patient and this syndrome. So he's 24, he's otherwise well, and he presents a progressive hearing loss, becoming much more unsteady. His walking is becoming unbalanced. He has a 6th nerve palsy, and he's starting to get headaches in the morning. And this is what his scan looks like. So quite a sizable tumor, as you can see, it's about 4.5 centimeters. It's got very slight enlargement of the ventricles, not enough for us to put an external ventricular drain in. Although he did have papilledema, but what we really wanted to do was deal with the acute problem. Okay, so what's my sort of thinking on how we manage this? I think the most important thing is you have to realize that these are different to other vestibular schwannomas. As I said, most vestibular schwannomas, it can be challenging, but actually you expect to get a very good result there. And you have to understand that this is a different operation and this is going to be much more challenging. You can consider staged approach. We have used that before. You have to decide, you're going to go retrosigmoid. What are you going to go for? Do they need EVD? My preferred approach is going for the cisterns, but that can be very difficult in young patients with large tumors, but that's something to think about. I think an EVD is not unreasonable. I personally don't use lumbar drains a lot, and I certainly don't use it with large posterior fossa tumor. I also don't embolize my tumors, but I think some people would consider that. There are downsides to embolizing. I'll talk a little bit about that when we look at the angiograms, but I personally don't embolize, but I think that's a very reasonable consideration. So these are some of the things that we've thought about, and you also get from the papers. There's an interesting phenomenon. I think Andres Grotinas spoke about this last time, that for some reason, partially resecting them, even if you don't get the blood vessels, and we saw that in that very first case, it reduces the hypervascularity. So they sort of autothrombose. And it's not entirely clear why that happens. 2B lesions, as I described earlier, this where they're being fed from both systems, they're the challenging ones. And wherever possible, even if you can do it in one stage, as in the second case I showed, that's favorable, I think. Obviously, we always want to protect the facial nerve. We'll talk about embolization a little bit. Again, I don't favor it. And some of the papers suggest that these behave a bit like AVMs, and there's a change in blood flow and you can get cerebellar swelling. I certainly saw that in the case that I had to back off in this case I'm going to talk about. I actually don't think that's the case. I think it's just a long operation, and because they're so vascular, you don't rapidly take the volume down as you normally would to really relax the brain down. And I think that's the sort of issue here with cerebellar swelling. I do like a large craniotomy for all of these. I routinely open the foramen magnum for them. I think it's just safer post-op. And I'm using standard techniques, but going quite aggressively with the hemostasis. Okay, so I know we have a lot of more junior people joining us. So just a quick discussion about what approach you would choose. So just to orientate everybody, this is the transverse sinus, this is the sigmoid sinus, and then you're looking down into the CP angle. You got the descending segment of the facial here and the labyrinth. So the options are to come behind the sigmoid sinus, retrosigmoid. That's my favorite approach for these. That's what I used in these cases. I think translab is very useful. I'm going to use that as a second stage for this case. And you'll know from my previous talks, for a lot of cases, particularly petroclavian meningiomas, I really like the trans-petrous transtentorial, so where we do a supratentorial craniotomy, middle fossa craniotomy. I go right through either retrolab or translab. I combine that with an anterior petrosectomy, and I cut the tentorium, and I think that gives a fantastic view down. And I have used that in one of these cases as well. But for the case I'm going to talk about, it's just going to be a straightforward retrosigmoid approach, and I think for a lot of these, that's enough. But as a skull-based surgeon, of course, you should be able to do all of these approaches. Okay, so this is the patient I'm talking about, just to show you it's a large opening. That's the craniotomy there. And you can see I've opened the foramen magnum. I've not taken C1 because I don't think it's needed. I've not drilled towards the condyle because I don't think it's needed. All I want is really open low. So I have a good chance of getting to cisterna magna or any of the cisterns. I don't think there's any advantage in having to drill the condyle. This is not a foramen magnum meningioma or something like that. And that's just the anatomy from Roton for our junior colleagues who are joining us, just so you understand. For most of your craniotomies, you know how the post fossa changes angle. You must get at least to this point. It's much easier to access cisterna magna, which is the first thing you do when you get in. I think it's even easier, particularly in young patients with big tumors, to just open right down to foramen magnum. That involves understanding how the vertebral artery winds around in that area. There's no need to take the C1 lamina. This is not a foramen magnum meningioma. You can see I've left the bone out here because we had some swelling. Okay, again, for our junior colleagues, just you understand the anatomy. This is the view you get in a retrosigmoid, a bit more than the standard view. The tentorium has been cut here, so it's not your standard view. You won't see 4 so clearly in 5, but you get a pretty good view of 5. Then you've got 7 and 8, and then you got the lower cranial nerves down here, and you can see the ICA winding through that. And understanding the anatomy of the ICA and the spinocerebellar arteries are very important in vestibular schwannoma surgery, particularly in these cases. Okay, then the next consideration is what is the blood supply of a vestibular schwannoma? And it's interesting if you look through the literature, again, maybe I've missed out, but there's not a lot of papers on this, but looking through the angiograms that we have done, again, we don't do a lot of angiograms, but I find these hypervascular ones very helpful for understanding the anatomy. The first thing to understand is there is a clear external carotid supply. Ascending pharyngeal, clearly salamastoid artery supplying some of these, but it is described. The tentorial branches definitely supply the tumor as well. And then, of course, the big feeders are from the SCA and ICA usually. So you've got very clear, large feeders, particularly in this case, from the SCA and ICA. And interestingly, also from the short perforators coming off the basilar. The pica can supply, but again, in this case, didn't really see a lot of supply from the pica. But you've got to understand that this is the blood supply of vestibular schwannoma, and how you're going to tackle all of this, either embolization or I think, my preferred choice is dealing with it intraoperatively. Okay, so the bottom picture, which is the least clear one, is just to show that tentorial branch coming to feed. But really what these angiograms, and I know it's not the same as flicking through the pictures yourself, but what it really shows that even in early arterial phases, you're starting to see the shunting of blood very quickly. And what you find if you don't time your CT angiograms and things well, you won't realize how vascular it is because the blood shunts so quickly through it. So if you're in a pure arterial phase, you might actually miss out on how vascular these tumors really are. And then you can go on to see there's almost 2 parts of this tumor. There is a vascular but less vascular part compared to the deeper bit, which is extremely rich blood supply, this rapid shunting of blood into the venous phase, mainly being fed by the ICA and this sort of large branch coming to the middle from the ICA and SCA feeders. So this is the vertebral basilar and internal carotid angiograms. And then understanding the external carotid supply is key. So I've annotated it just so it's very clear for everybody. So the first thing you have to understand is middle meningeal coming up to spinosum for that sort of classic turn. And here you have the petrosal branches as an accessory branch as well coming through. Now, the difficulty, of course, is accessing these branches to sort of embolize it. And if you want to embolize something, I think the external carotid is not a bad option. But you run into real difficulty because you have to understand, what the rest of the anatomy is. So these yellow arrows, this is the internal auditory canal. This is sort of feeders coming towards the area of the genicular ganglion. So it's actually very easy. Well, sorry, first it's technically difficult, but then secondly, it's actually very easy to start injuring or making things ischemic that you don't want. It's obviously the tumor there. Then you've got ascending pharyngeal, and understanding ascending pharyngeal branches, inferior tympanic artery. Superior tympanic is obviously a branch of middle meningeal. What the superior tympanic artery does, how it enters in through the jugular foramen. How the branches enter through the jugular foramen and also through, along with Jacobson's nerves, how those vessels then come up to feed into this tumor is very important to understand. And as I described earlier, but probably the easiest bit to get are the occipital artery feeders, these transosseous branches coming off the occipital. So all of these are important feeders as well that go on to supply the tumor. And you can see the blushes coming from both internal and external. Some of these ascending pharyngeal ones can anastomose with the vertebrobasilar system. So again, not a good target, I think, for embolization. So my preference is not to embolize, but I can fully understand why other people would. And it's certainly something you must consider. Finally, the final thing I like to do is this 3D spin. We've got excellent neuroradiologists here at Oxford, and they give this sort of double contrast view and then do this 3D spin, which I find extremely helpful for really understanding in one view, in a view we're used to. The double contrast is, it differentiates between this bright arterial. This is a view of the top of the tumor, an axial slice right at the top, big feeders, SCA feeders at the top. How that's going into the veins. You can see small amounts of arterial phase already in the veins. How vascular the tumor is in the deep aspect, where the veins are here on the deep bit. How this picture on the right here, the coronal view, what it's showing is the huge feeder going through the middle of this tumor and all the little branches coming off the ICA. I find that very, very helpful. There's also flow-related aneurysm picked up here, just where the labyrinthine artery comes off the ICA. So this is, in terms of preoperative planning, is all incredibly useful to know. You can see there's almost two phases of this tumor. The deep bit is even more vascular. So you can make rapid progress, hopefully, in the superficial or the lateral part. As I said, you can put an EVD, I think that's fine. I don't use a lumbar drain. And then it's really about going for the cisterns. In this case, there's almost no CSF in cisterna magna. And so you're looking at really at, the cisterns at 11 there. There's a lateral medullary cistern and it's incredibly tight, even with very, very good anesthesia. It was very, very tight getting into this brain. And that bit is critical. If you injure the cerebellum or anything, your operation then becomes even harder. And getting the initial CSF is what made this possible. Okay, so just to summarize again, I think you should do a big craniotomy, open to foramen magnum. You have to get the CSF, expect a lot of bleeding, but you should be able to manage it. The other thing I find useful is actually minimizing the use of the ultrasonic aspirator, otherwise the bleeding just becomes very hard to control. Sort of old school technique of using the bipolars to try and resect tumor. And I'll show a bit of that in the video. And it's only after you really debulk the tumor down that you have any chance of doing the standard arachnoidal dissection technique that you would use in a vestibular schwannoma, and you've got to keep an eye out for cerebellar swelling. So I'm just going to show the video. So I'm sorry, I couldn't show you how this is actually after I've drained a bit of CSF from the lateral cistern. It was much tighter than this was. And this is, of course, much tighter than a normal, VS surgery would be. Normally, by the time of good anesthesia, nice craniotomy, drain cisterna magna, you got quite a bit of space already. The cerebellum has fallen back. You can rapidly, so I'm just trying to peel some of the arachnoid back. You can rapidly debulk into this. And you get a much more relaxed brain. I mean, this is not a relaxed brain at all, and not in any way typical, I think, of a vestibular schwannoma operation. and I can't rapidly debulk here because of the vascularity. So I'm being cautious initially. I would like to do a lot more arachnoidal dissection. I think one of the worst things you can do, obviously, is to fuse the arachnoid in any extraaxial tumor. Fusing the arachnoid onto the tumor is just criminal. But anyway, I'm already, as soon as I got in, I was starting to get some bleeding from that sort of petrosal branches. So I've started there, tried to do a little bit of debulking and having to coagulate. I have to say I'm not a big fan of bleeding at the best of times, and like to keep it under control. I like to have a sort of nice cavity the blood can run into inside the tumor. So working the lower pole, I'd like to get more CSF. You can see the low cranial nerves here. We're just starting to separate away the tumor. Got a reasonable understanding of what's happening with the anatomy. So I can start to coagulate. I know I'm away enough from some of these. And I'm using the bipolar. I'm trying to stay outside the tumor actually as much as I can. When I go inside, it's usually to use the bipolar to debulk. Not too bad actually at this point. I think we've stopped a lot of the early bleeding we had. Just going to skip forward a little bit. Yeah, so it's starting to come away. Low cranial nerves are starting to come away. Taking some of the feeders there. I'll just skip forward some more. The video's a lot of staying in the same area and trying to get on top of it. And I'm also getting CSF the whole time, which I'm happy about. And things are relaxing down a bit. I think we switched to sharp dissection at some point, and those nerves come away quite nicely. Unfortunately, we have safety scissors, so this is like pulling away rather than just a pure cutting. Yeah. Okay, and a bit like, in a hemangioblastoma, I know where the facial nerve, I've not picked it up yet, and it actually turns out to be much deeper. I know I'm safe. So you can see quite significant feeders to this tumor, all of which we're going to take. And I'm very clear from the angiogram, what I can take, what I can't take. So we're just continuing to clear away, still working at the bottom. I think I'll skip forward. And as much as possible, I'm trying to, a bit like a hemangioblastoma, really take the outside of this, coagulate it down. Just keep going with that. So I'm going to skip forward. I'm going to come to the top of the tumor soon. It's more just coagulating. Coming up top, I'm expecting big feeders here as well. I know from the angiogram there are big SCA feeders. That's a branch going into it that I've just taken. Yeah, so now this is the bit where I'm using the bipolar. I've tried with the Sonopet. I actually found that much slower, the Sonopet. You can see there's quite extensive, bipolaring going on in this case. And I'm actually debulking the tumor down with the bipolar, and that was actually the best way to make progress in this operation. And that goes on for a lot of this operation, is actually trying to get the volume down that way. Anyways, we get the volume down, we start to come, and we're going to pick up 4 and 5 at the top. We're going to pick up the SCA, so that's the fourth nerve there, and the arachnoid. SCA and the feeders are here, part of the Dandy complex that it's feeding into. So you can see once you get the volume down, actually it comes a lot more like standard vestibular schwannoma. It's still the bleeding issues. Yeah, just clearing away the arachnoid. I'll skip forward here. You can start to see the feeders and the depths, and I take the branches off that. Okay, so we're coming down onto 5. We're going to come onto brainstem in a minute. I'm just working out that there definitely is a feeder, which I take a bit later. Just taking the branches coming off it. So I'll just skip forward. So we're coming down towards the brainstem here. So it's got very nice arachnoid planes. That's 5. Oops, sorry. We're now on the brainstem. Now here on the brainstem, I just haven't got the volume down as much as I like to. It's not as, the brain's nowhere near as relaxed as I'd like it. There's a bit of swelling. That was just that bit. That was me taking the feeders off the brainstem. It's just to show that it peels off the brainstem, but it's all, everything is just a lot. It's a nice plane along the brainstem, but everything's just a lot fuller than I'd like it to be. So I decided I should stop. I'm going to come via a separate approach. So I stopped because I felt it was just a little bit of swelling there. I don't use retractors. I like everything nice and relaxed when I'm doing things. So I got about 70% of it out, but obviously there's still a lot left. You definitely wouldn't leave this in any patient, particularly in a young patient. So I'm going to go back in on a staged approach that some of the papers recommend. But the patient's a lot better. A lot of the mass effect, this is an early MR, is even better than this now. His walking is much better. His double vision is getting better. Facial nerves intact. And he's very well. And we're going to come back for a second stage. Okay. And that was the case. Thank you very much.
Thank you, dear Professor. Do anybody have some question? Please, Professor Ahmad Kanan, go ahead.
Yeah, we got a lot of experienced vestibular schwannoma surgeons here. We've all turned the cameras on.
I have several comments on this case.
Yeah.
I know large vestibular schwannoma can be very challenging. First, what kind of position did you use?
So Iman, I don't use your sitting position. I go park bench.
I do park bench, but simulating sitting position by elevating the upper trunk up, and I think Ramesh knows about it. Now, one thing, I never take foramina magnum posterior limb on these cases. The second things, all these fancy angiographic studies and supply, I think they are in the peer of the underlying tissue. Once you see vessels on this schwannoma, you are not in the right plane. And this is what Professor Sami insists. Arachnoid dissection is an essential. And it's very difficult to do it when you have a major bulk, unless you reduce the volume of this tumor to initiate a relaxed arachnoid that can be dissected. But dissecting the arachnoid while the bulk is there is very tedious, and you see all these congested vein, and you start coagulating, and it adds to the swelling. This is one. About lumbar drain, generally I don't put it, but in the recent years, I'll put it, but I don't drain. When I open the flap, once I open the flap, I drain 10 cc, and I learned from Professor Yazerjil to do a small slit incision on the lower part of the exposure, put a patty, lift the cerebellar hemisphere to reach to the cisterna magna, and open the cisterna magna before you open the dura completely. Because once you open the dura, that swollen cerebellum will herniate. It will be like a strangulated hernia, will be more necrosis, more swelling, and it will be very difficult to proceed.
So I'll just make a comment on that, Imad. So I do exactly the same thing, but there was no CSF in the cisterna magna. I was right down. It was only in the lateral cisterns where there was CSF. But routinely for most vestibular schwannomas, I do exactly the same thing. Small cut,
you do the same.
Cisterna magna, the whole
this
thing
is
relaxes
for the
down.
Education of the young generation. They should know about process, how we go. And then we'll go to the cistern. Now I saw that the caudal nerve were naked. I don't make them naked from the arachnoid. I open the arachnoid, but I keep the arachnoid on them because this is very important. It tells me then I am in the good plane. You open the arachnoid, you get the relief of CSF, but I leave the arachnoid like I call it the natural patty on these nerves. And the same for the trigemina. I open the cistern, but I leave the arachnoid on there. And then I start walking in the center. The other thing, I didn't see irrigation. Well, if you go with Professor Sami, I think he irrigates perhaps 10 liters of water during the surgery. He does not bother about the small ooze because we know vestibular schwannoma is a vascular tumor. And this is why the Antony B, when you open on this, they are cystic or xanthochromic. Why they are xanthochromic? Because they bleed inside themselves and because of the short shunting you were talking about. So I'm not bothered about, I keep irrigating to achieve fast central decompression of these lesions. And sometimes the horrible decusa or whatever it is not working for you. But
Iman, I agree. In a standard vestibular schwannoma, I agree with all of those things. In these ones, and I've done a few, not a lot, and probably not as lot as you maybe, but in these ones, these are different. Trying to get irrigation does not cover the hemostasis. It absolutely holds the blood on you.
Yeah, because
I agree. Most vestibular schwannomas, yes.
Yeah, let me continue some of the comment before I leave the venue for the others. Now, the other thing, even he is young, 24, and that rim you left, I don't insist to go after it because I'm seeing there is no arachnoid space between the brainstem and the capsule. And these are where you get trouble for the brainstem. These veins on the brainstem, they will start oozing like hell, or you start coagulating. He will end with venous infarction in many of the cases. There are areas there you see arachnoids, but some of them, if you are not well decompressed, but you have 70% decompression, yet the space is not open next to the brainstem in some area. So we have to accept sometimes to leave. And I remember Professor Majid Sami, if he see that severe adherence to the brainstem, he doesn't bother about dissecting these veins because they will be a troublemaker. And you end for a benign disease, a malignant outcome. That's why I think where you stop was correct, but I don't like the amount of charcoal I'm seeing on the surface of this resection.
I agree with that, but this is a very different case, Iman.
Being there is different than retrospectoma. I'm talking in general conditions for education, but I understand perhaps you have more bleed, more vascularity, but these are my comments.
No, I agree fully with that for most vestibular schwannomas. But I think these are different. Anyway, let's ask Bassan. He must have done a lot of these.
Yeah,
and Henry.
Bassan has a major experience.
Yeah. Okay, very nice demonstration, but I agree with a lot of which Imad said. There's a couple of, there are 9 ways of skinning a cat. So obviously there are different ways of doing things, but I think general principle, I would agree, but I do something different. I have about 1,000 cases now operated acoustic. I have never done a lumbar puncture, and especially giant acoustics, it may not be without danger. So I wouldn't do it. I sometimes do for large skull-based meningioma where there is no pressure. And I do exactly what Imad said. Don't open put the lumbar drain. And after you have done the craniotomy, then only open so that you don't have the bulging, herniation. But one trick for the giant, in India, we see all the time these big tumors. And I agree with you. The young patients with giant tumors are much more vascular. You can put a label as hypervascular, but they are often very vascular. Now, if you go to British Journal of Neurosurgery, I have reported in 100 consecutive cases with Imad actually told about this Anthony B. They are much more likely to bleed. And we have 7 cases out of 100 with a consecutive series who had bleeding, presented with bleed. And so young, and they were all Anthony B. So Anthony B, young patient, giant tumors are much more vascular. One trick which I have learned over the period of years to relax the brain is go down. I always, unlike Imad, especially if you're doing in lateral position, I do both. I do both positions. If it's a giant tumor, I do semi-sitting like Professor Sami, but if it is not a very big tumor and not very hypervascular, I would go for a lateral position. But one trick in you are doing in a lateral position, the brain is of course much more fuller. Go down on the foramen magnum. Do not try. You're right. You will not get any CSF in the lateral. You do not get CSF in cisterna magna. Go below it because already tonsillar herniation is there below the tonsillar herniation. So I don't do the C1 laminectomy, but you go just above the C1, open below the foramen magnum, and you release the CF. I did today a case actually. I did, and for some reason, Professor Sami had called me for something, so we are discussing this thing. So that's interesting. So it's a 5 centimeter today. I did about 35-year-old young lady, and very tight, like what you said. But the moment you drain the CSF below the foramen, don't try to do it at the cisterna magna, lateral middle. You'll not get it. So below that, it lacks. Number 1. Number 2. I agree with him. You have used, I mean, of course, it's a difficult case, but you have used bipolar like mad. I mean,
I have.
I mean,
I
the
don't
trick
normally,
is
but
not
I
to use
have.
bipolar. My dear friend, the trick is, like Imad said, not to use bipolar. Avoid it. Go quick. See, these are not AVM. They will bleed. It doesn't matter. He's not going to go hypotension for bleeding. So the faster you decompress, the better it is. The moment you decompress, everything is, brain is lax, is nice, pulsating, and it's much much better. And I agree with a lot of things which Imad said, like covering the arachnoid, the nerves with the arachnoid. That's the best cover. There's no question. Interestingly, 1995. I presented, and there was a symposium with Professor Dolench was there, and myself was there as a breakfast symposium, Asian Australasian Taipei. And he was presenting a acoustic, I was presenting acoustic video. And this was a long discussion. He said, I would like to, I mean, I respect Professor Dolench. I have learned a lot of things from him. But this is one thing which I don't agree with him. And we had a long discussion there. He said, I would like to expose all the nerves. I would like to see everything. I said, I would like not to see anything. Because the more you try to open it, the more, and the arachnoid is the best cover. There's no question about it. So the only differing point, my dear friend, is very fast decompression. Don't try to achieve hemostasis. It takes much longer time to do that. Very fast decompression, open below the foramen magnum. Don't try at cistern, you will not get CSF. I agree with you. Giant tumors, I don't do lumbar puncture. I have never done it. I never ever had done an angiogram in acoustic. We don't need it, actually. And if you see Professor Yasser Gill's monograph and the articles on acoustic, the first thing he has written, where is the blood supply? Ascending pharyngeal. Goes into the posterior pectorus, and you coagulate that, the bleeding much less. And like Dr. Kanan said, Imad said, they are, if you are hitting all the vessels, you are outside the plane. It is unlike vascular surgery, it is extra-arachnoid surgery. Vascular surgery is subarachnoid surgery. Tumor surgery, I have told all the time, every time in my talk, benign tumor surgery is extra-arachnoid surgery. Don't go to the subarachnoid space. But it's a nice demonstration, especially for young people. You can get stuck, but like Imad said, always come back. It's a benign tumor. You can wait and see. There's nothing. As long as the patient is good, it's fine. No problem done. Thank you.
I agree fully, but I have to keep saying this. I think these are different, but maybe it's just for me. Andreas, you want to help me out here? We've talked about.
I want to help you out.
We are not fighting you. We are discussing, but let them help you. No problem.
No, okay. Listen, during Kiki Terrell's meeting, I presented a similar case that, 30 years ago, and it really, I had done recurrent cases of schwannomas, a lot of schwannomas, and all of a sudden, this was a completely different thing. Within 40 minutes, I was losing 2 liters of blood. So this was, and that never happened anywhere later on. Well, then I knew about these hypervascular cases. And I disagree with Imad and Bazant because in these cases, and that's the special subgroup, there the vessels are inside the tumor, and they actually, they shunt even inside and also on the surface. Even if you strip the arachnoid, under the arachnoid, you see like snakes around over and they were, the moment you open the capsula, the capsule was blushing blood out of it. So
Yeah,
this is
I agree.
different from because everything you said is absolutely the trick on vestibular schwannomas, but these are the 97% of normal vestibular schwannomas, and even the giant ones. The largest one that I actually had to do acutely because of herniation was 7 centimeters. And still, all the things you say are true there, but not in these little subset of hypervascular lesions. I agree also with you, Sanjay, that they are not associated with NF2, oddly, because these are young patients. That first patient was 22. The second that I had was 17. So it's very odd. And you would think that must be then NF2, but that is not true. This is a special subset. And it is, and since we are not doing angiograms routinely nowadays, not even MRAs in schwannomas, we not always see it. But if you look carefully to the T2 sequence, you see a lot of inside the tumor, not outside, inside the tumor, you see all these black snakes inside the schwannoma. And that's the
I
difference.
think Ek want to say something, yeah, isn't it?
And Henry as well.
I want to comment on this too, because I think as much as Prasant and Imad have a good point to make about general vestibular tumor, this is where I side with Andre. There's a subset of CP angle tumors that is completely different from the rest out there. And we published a paper in 2017 on hypervascular lesions of the CP angle and the role of angiography in that subset. And I really think one shouldn't dismiss a diagnostic tool if it is available, because especially early in your career, Prasad, not everybody has 1,000 cases under your belt. You know, you want to have all the information that is out there to prevent from running into trouble, which may not be beyond the arachnoid. It may be, as Andre said, inside the tumor. I've only seen like 3 of these cases in my career too. I don't know what they are, but I think they don't fit the regular system, and they catch you by surprise. I mean, if Andre loses 2 liters of blood in the first 40 minutes, you know, in the hands of an experienced surgeon, that is a big surprise. So why not go for the angiogram if you have a suspicion?
I was at that time, I was thinking I was operating on an unexpected AVM. That was my feeling at that time. At that time, I was not that experienced. So there was.
I think the message is taken from you guys. We'll give Henry the chance to comment. Henry, and then perhaps
Andre missed it. It was not a vestibular schwannoma, but it was a hemangioblastoma. That's why he had this hemorrhage. So I just want to say,
was schwannoma.
I agree, Sanjay. If you have a lot of hemorrhage, you have to coagulate the vessels. There's no point. I think it's okay. But what I really suggest would be to make a sitting position. If you have a sitting position, you have an irrigation of your assistant, and you always have a good plane. If you have all the blood inside, it's very difficult to keep the plane. And if you have bleeding vessels, then it's even worse. So for these cases, I would strongly advise to have a semi-sitting position with constant irrigation. That will help in this situation.
I think unfortunately in my hospital, if I try and do a sitting position, all sorts of alarm bells.
No, you can't. I think Britain, they can't do it. I mean, they are very worried about it. I mean, most North American centers will not allow that. But it's not without, I agree with that, it's not without risks unless until the anesthetist is very conversant with the sitting position. So we do, as you said, we do for giant tumors, we do semi-sitting, but for smaller and medium-sized tumor, we don't do it because there is definite risk of having a problem which is not under your control. It's under the control of anesthetist. So I would like to avoid that. That's correct. But I agree with you. For giant tumors, we try to do a semi-sitting position. Just take one. I mean, there are always any acoustic will be very difficult. Any acoustic could bleed a lot. But I think there are always vessels. But you could go down to the feeding vessel and coagulate. That's correct. But I would not try to decompress with a bipolar forceps. That's what I was trying to do. Not that you don't need to, sometimes very vascular, you need to coagulate. That's correct. But I would not do a bipolar decompression. That's much slower procedure and you are going to get stuck. But please take one, just last point I'll make. Please take one tip from me. And this is, I've learned it over a period of years. Go down this giant, not any tumor. I don't open the foramen magnum for medium-sized tumor, and I don't ever open the foramen magnum if it is a semi-sitting position. But if you're doing in a lateral position, because I do both, if you're doing a lateral position, it's a giant tumor, go down below foramen magnum. Do the next 2 cases that way, and you will see the difference. The moment brain gets lax, all the veins, everything becomes very nice, and the brain is soft, it's not angry, you have a lot of space to work around, and you can coagulate the vessels, but which is going inside the tumor. And there are sometimes, and obviously we see this quote unquote very hypervascular tumors. I do not agree that you need an angiogram today. Sorry, my friend, because you have today the technology which you have, the T2, you can have everything, all the information on MRI. You want to do it, do a CT angio. I mean, you don't want to do an invasive procedure for an acoustic, for an angiogram. I don't think I would agree with that.
Ramesh.
I just want to comment, Prasanta, I think the sitting position is not common in UK for acoustic, but if you do it for the supratendial approach, so it's not that uncommon sitting position. But coming back to Sanjeeva's case, I remember a case where we had a CP angle lesion, which we thought was hemangioblastoma. And so the patient had all the angiogram, and also there was feeding vessels into it, and the endovascular guys had put some embolization material inside it. Actually, when we went in there, it turned out what it was a melanotic schwannoma. It's a very rare kind of schwannoma, which is called a melanotic schwannoma. And it was very vascular. I don't know whether it comes under this category of hypervascular schwannomas, but it was an unusual kind of schwannoma called the melanotic schwannoma.
Victor, we want to give Dr. Kiki Torel. He has spent, I think, 1 or 2 years with Professor Sami. Can you reflect on vestibular schwannoma, and if you have some recommendation from you have done and you have learned from Professor Sami?
We've had, we've seen all kinds of patients of acoustic neuroma with him. The most important thing is that he does sitting position for every size of tumor. Even an intracanalicular tumor, he does a sitting position. So it's nothing to do with sitting small, medium, or large. All of them are done in the same way. And of course, he has a superb anesthesia team and the transesophageal Doppler and so many other things by which you can diagnose your air embolism. Sami does not wait for coagulation. I agree. He just goes on, the assistant goes on irrigating, and he goes on removing the tumor. And he uses CUSA quite frequently, quite often, all the time. And I personally feel that even if it's a vascular tumor, your CUSA will help you to decompress much faster than if you have to do by the normal standard neurosurgical tumor removal instruments. So use your CUSA without, I mean, you will tear vessels, you will cut through the vessels, but it doesn't matter. You will be able to decompress much faster. And for some reason, Sami always finds a good plane of arachnoid, and he always manages to keep everything outside the arachnoid so that he's basically focusing only on the tumor. And as we made that very famous statement way back in the 80s, is that tumor removal, and this is my own statement, tumor removal is only a byproduct. Saving the cranial nerves is the goal of the operation. So the goal of the operation is preserving the nerves, preserving the blood vessels. And I mean, if you go with that philosophy, and tumor removal is just a byproduct of the whole procedure. So, I have not seen this kind of bleeding for the time that I was with him, but I completely agree with Sanjeeva that you will occasionally come across these tumors, and you have ways to know that they are going to be vascular. But except one case very early in the 80s that I did an angiogram, it was on the insistence of the radiologist. But otherwise, we have not done any angiography on any patient, and we manage the patient the way it is. Yes, sitting position is cumbersome because of its problems of air embolism. But if you have a good anesthesia team, then I think it's a much better way, especially for large and vascular tumors, compared to any other position. And it has certainly great advantages.
No, I agree fully with everyone, and I agree fully that you should stay in the correct, not subarachnoid, but in the extra-arachnoid plane in 99% of vestibular schwannomas. But I'm going to stick
we always, I mean, having said that, we miss it. I mean, it's not that every time we can do that. I mean, it's not Sami, everybody's not Sami. We do go miss, we do cut the nerves, we do damage, and all that is there. But this is the principle. But only one thing, I think even if it is a hypervascular tumor, the technique of trying to decompress it bipolar is counterproductive. It's a much slower procedure. Take it from me.
No, I agree. I don't normally do that, but this was different bleeding.
Doesn't matter. Let it bleed. Let it bleed. I mean, you just pack it. You put some cottonite inside. It bleeds. I mean, you from India. I mean, you know what tumor size we get it in India. I mean, very, very often we see, and some of them we have not described it, but some of them are very vascular, and we do bleed a lot. And of course, there is, as I said, I mean, you are a very senior neurosurgeon now, but I tell all my young neurosurgeons whenever I meet it, there is no shame in leaving tumor there. And your patient is grade 1 facial, what do you want? What more do you want? Like Imad said, and 70% is out, so that's fine. I mean, you can always go back whenever it's necessary. So there is no shame for the young neurosurgeon, not for you, of course, but for young neurosurgeon, there is no shame in leaving tumor. I have always told, and it is never bad to leave tumor, have a good patient, rather have a good MRI and a bad patient. There's no question about it in my mind.
No, I think the tumors grow rapidly, actually. So
yes, they do. Young patients, yeah, they're you're right. They're non-NF2 young patients, and they're giant tumors. They enlarge, and we see all the time. See, we leave a tumor. Somebody has left a tumor. We ask them to come back to follow up. They don't come back. They come back again with the same 4 centimeter size again. You see, that's not unusual in India, unfortunately.
I have seen one terrible complication in a sitting position in Germany, and a young patient developing quadriplegia after sitting position. And
Keki, I have presented in your complications meeting one patient, young lady from Bangladesh, and I preserved everything. And the patient woke up paraplegic. We did an MRI. Fortunately, it's only ischemia. This was semi-sitting position. And that patient onwards, we changed our strategy, and we are very, very cautious. We have everything like what Sammy has. I mean, our anesthesia team is good. But this does happen, and only a short period of little bit of blood pressure drop, no CO2, no air embolism, but 90 systolic, and that's about it. Fortunately, the patient improved, and I had presented in our complication meeting, actually.
I'm aware of it. Yes, sure.
Dr. Sanjeeva, it was a really interesting case. It woke up passionate comments, so it's really interesting.
Yeah, nothing like breaching arachnoid to really wake up the skull base surgeons.
Another question, another comment. Professor Henry Schroeder, you have the hand up.
Oh, this is by mistake. I think everything has been said.
Thank you so much.
Each case is different, and you have to make your decision. And I agree, sometimes the same sitting position has strange complications sometimes. Although we have this echo, we have all this monitoring what you can have, but you can have severe pneumocephalus in older patients. And we had one patient, she lost completely olfaction simply because of the pneumocephalus. There was so much traction on her olfactory nerves that she has no olfaction, and she's suffering from that. So sometimes unexpected things can occur. That's why I agree with Basant. If we have smaller tumors, we make only simply supine position and turn the head to the other side, and then we rotate the whole table. That's enough.
Thank you. Dr. Ahmad.
All right, I think we are all tired. First, I'd like to thank Professor Sanjeeva for bringing that case, that we got nice discussion. And I have to tell him, we are with you, not against you. You don't need to ask for help.
No, thank you for bringing that case. I mean, that's a very interesting case.
Wonderful.
By the way,
Tangiba,
it happens to all of us. It has happened to all of us over the period of years. So you are not unique. So don't think
you
that
are
you
not
are
the
unique.
only one. Neither you or the tumor. This is not unique cases. It's a very interesting subject to bring. I'm glad that all of you enjoyed the discussion. All the presentations were marvelous, each in his field. And I think the 2 days were, hopefully you found them successful days. And I hope the spirit will continue to move forward for the next webinar. Shortly, I will send the timing and get your presentation suggestion as soon as possible. Don't stay for after 6 weeks to send me a presentation.
So Imad, can I make one point, please?
Sure, yes.
One last point is that we are going to have our next webinar on complications, where we are going to talk about major complications in relatively minor operations or minor surgeries. So what we consider as routine or regulation operations or minor operations, and we have major complications. So remember that it'll be the end of May, last Friday of May. People may like to present their severe complications following minor surgeries.
We do never minor surgeries. We only do big surgeries.
Yes.
Well, Keki, what I heard is that the only minor operation is the one somebody else is doing.
Exactly. That is what you should tell your residents, indeed.
Okay, so on behalf of Vladimir and myself, I'd like to thank you all and have a good day. Take care.
Thanks.
Bye.
Bye-bye.
Bye-bye.
Bye. Bye. Bye, Takashi.
Bye. Have a good weekend. So
Same to you.
yeah. Okay.